All right, it is officially 1:15, so we'd like to start on time because we know that we use up every single minute at these meetings. So we'd like to welcome our presenters for our next panel as we continue our discussion about communication during times of emergencies. I'd like to transition now to Dr. Elaine Larson, our moderator for the next session.
Thank you and welcome again. Actually, Dr. Dixon's last comment before the lunchtime is a great segue to this session. He mentioned that the important thing was communication. So we have an interesting panel now on external communication with the public. I'll introduce Andy King from the University of Utah, who's speaking about communication challenges among AMR and AMS in the animal agriculture during a pandemic. Andy?
Thank you, and good afternoon. It's a pleasure to be here and speaking with you. And indeed, I'm going to talk about some communication challenges about antimicrobial resistance and antimicrobial stewardship in animal agriculture during a pandemic. Next slide, if you would. The takeaway is where I want to start, and then I'm going to go through some other points, and I'll circle back to this at the end. But the takeaway of this talk for me is that communicating about antimicrobial resistance or stewardship during a crisis is challenging for animal agriculture stakeholders because there are unclear communication strategies and behavioral recommendations when there isn't a crisis. So to put that in a slightly different way, because things aren't necessarily clear and recommendations aren't clear about what to do to be a good steward for antimicrobials, and then there aren't any definitive recommendations, it's really hard to come up with a communication plan about what to do when there's a crisis if we're not necessarily communicating that clearly when there isn't a crisis. Next slide. And so the talk is going to go through sort of three main areas. First, just sort of provide an overview of some science communication challenges in animal agriculture as they relate to resistance and stewardship. Talk a little bit and very broadly about communicating during a crisis. Obviously, crisis communication could probably be its own panel and could certainly be its own session. So I'm just going to give just a brief overview of what that might look like and why that's important to consider. And then end, again, sort of where I started, which is sort of the need for recommended behaviors and communication strategy to improve stewardship, both in a steady state and a crisis state. Next slide, please. I will say I love giving these talks because I do my other sort of area of research is cancer research, and those visuals are always less interesting than goats and other livestock. So I am happy to be able to share those with you too. But to talk broadly about some antimicrobial resistance and stewardship challenges, communication challenges in animal agriculture, it's important to start thinking about what we mean by public communication in the context of animal agriculture. Indeed, this panel is called External Communication with the Public, but realistically, from a public relations perspective, there are multiple publics in any area, but particularly in animal agriculture. And so I highlight 5 of these groups on this slide. This isn't an exhaustive list of potential stakeholders, and obviously there's overlap in these groups, particularly in animal agriculture. Just as nurses and doctors are members of the public, so are producers and farmers part of the industry in animal agriculture. But I'll talk about each of these groups individually, and then just sort of discuss a little bit about how different goals and values in these groups make communication challenging. And so for producers and farmers, in some research that we've done looking at antimicrobial resistance and sort of feelings about what are the important things to consider, we find that protecting animal welfare and protecting operational sustainability are two things that are really important for producers and farmers, understandably. For veterinarians, the goal is to help clients and clarify misperceptions for their various stakeholders. That could be members of the public that sort of see them as experts, but also producers, farmers, industries, representatives or employers, as well as government and policymakers and those that enforce regulation. In industry, and when I say industry here, I mean that broadly considered. So this might be someone who's a producer and farmer as well, but it could be someone that also is a representative for a corporation that has public stakeholders and stockholders for that matter. And so for the industry, there's a goal and sort of a value of increasing consumer confidence in decisions related to antimicrobial use, as well as influence policy to avoid too much regulation. And sort of promote some self-regulation. For government and policymakers, a lot of times the priority has been stated as biosecurity, compliance with regulations that are existing and obviously are believed to be helpful. And for the public, we're looking at concerns about health and well-being and a sort of desire to sort of quote, be in the know. But beyond regulations, there's really no consensus or definitive guidance about what actions these stakeholder groups should take to encourage stewardship, and that's in general or in a crisis. And so that makes it a little bit challenging. Next slide, please. Because in addition to having those sort of multiple stakeholders with different values, there are also unique communication concerns related to those values and obviously related to the sort of various responsibilities these stakeholders have. And so for producers and farmers, there's some concern in communication about public hostility toward animal agriculture, and also a lack of consumer knowledge that sort of impedes that conversation. Again, this is the perspective that's been shared in some past research. For veterinarians, there's concern about ineffective delivery of complex and nuanced information, as well as sort of varied client responses and reactions and managing those responses and reactions. Again, this is true both in a steady state, but also in a crisis. COVID-19 is a good example of a time when veterinarians faced some challenges in terms of delivering care, establishing care, and also sort of making decisions when there were restrictions that could have affected movement, for example, in particularly rural areas. For industry, some communication challenges and concerns relate to the sort of desire for consumer accepted language regarding the complexities of antimicrobial resistance and antimicrobial use, as well as addressing what they see as sort of myths that are perpetuated by media sources, of all sorts of media sources for that matter. That's not meant to be a monolithic declaration about media, but to say that there are a lot of sources of information about animal agriculture and about antimicrobial resistance and use. And so addressing some of the myths, concerns, and misconceptions. For government and policymakers, the communication concerns, again, are different. Stakeholder misunderstanding of antimicrobial resistance, that is shared with some of the other stakeholder groups, but is obviously of interest to the government, and also concern about inconsistent messaging, which I'll talk about on the next slide when it comes to crisis communication, why it's important to be clear and concise with messages, particularly in a crisis. And then the public, there's often a desire for these communication challenges to have their voices heard and sort of have their perspectives and worries sort of taken into consideration, both in terms of decisions that are being made and also actions that are being taken by all of these stakeholder groups. And so there's an additional challenge, of course, in making communication recommendations across stakeholder groups because their key audiences are different, and you need to make your communication recommendations based on those audience characteristics, as well as, of course, what your communication goals are as the communicator in one of these stakeholder groups that exist. And of course, each of these groups have complexities in terms of how important communication might be to their operation. Next slide, please. And so to think about this, all of those communication challenges that I outlined are really communication challenges in general, in talking about animal agriculture across these different stakeholder groups. And so communicating in a crisis presents a different and unique challenge. And so communicating in a crisis, again, this is a very condensed and consolidated version of what it means to communicate in a crisis and what you might do to communicate in a crisis. But to do this well, to engage in crisis communication well, you need to plan well in advance, but also remain flexible, be willing to adapt. And adaptation comes up in the third point as well. But it requires a plan. But to plan for a crisis, you have to plan. It's beneficial, I should say, to plan to have a general communication strategy all of the time. And again, a lot of times, those various stakeholder groups that I outlined don't have a communication plan, or it's an outdated communication plan that, for example, isn't particularly responsive to the current communication environment that we operate in as communicators. Another thing about communicating in a crisis that's important is to respond quickly and transparently, which means also potentially acknowledging uncertainty about knowing what's next. A lot of crisis communication consultants will tell you that the sort of speed of your response is really important to consider. Sometimes you want that to be a little bit delayed, but if it's too delayed, that can be problematic and sow mistrust among the various publics and stakeholders that you serve. And so again, having that plan in place is important, and having a clear sort of spokesperson and also sort of a strategy to get information to your various stakeholder groups that you serve is important to keep in mind, but also being willing to acknowledge uncertainty. And I think that some of the retrospective analysis of how people responded in COVID-19, perhaps there's some desire to wish that there was some additional sort of acknowledgement of uncertainty at various points over the past 3 years. The last point here is you also, in the process of responding to a crisis and communicating in a crisis, you need to plan well in advance, but you have to also plan to monitor stakeholder response, and be ready to respond in turn and be ready to adapt. And that's a challenge because monitoring stakeholder response is probably easier than it ever has been before for some media types and for some message platforms like social media. It's obviously very easy to monitor that. It can be harder to monitor sort of that non-public communication environment where people are talking in private or having conversations that don't become public for a while. I think this is particularly true for those involved in animal agriculture. Next slide, please. And so I want to end on the takeaway that I started with, which is, there's a need for recommended antimicrobial stewardship behaviors and a need for communication strategies in animal agriculture, broadly considered. And so right now, as far as I understand it, there is no definitive consensus on what AMS behaviors various stakeholders should perform, and that is, there are some recommendations, for example, about use, but there are not definitive recommendations about things beyond use. And without clear behavioral recommendations, any communication strategy, again, that could be in a steady state or in a crisis state, has limited value. And so I'll end with the takeaway and then make a few more comments before my time is up, that at present, communicating about antimicrobial resistance and antimicrobial stewardship during a crisis is challenging because there are unclear communication strategies and recommended behaviors when there isn't a crisis. And again, I think that's ultimately because, as I sort of see it, antimicrobial stewardship is really referring to a sort of a constellation of behaviors of interest, and that's about more than use. And that's probably particularly true in a crisis, because in a crisis, you might have goal behaviors that are different, like increased diagnostic test use, more disclosures about symptoms to veterinarians, changes in reporting of various information related to use or diagnoses. A number of things that are, as a communication expert, beyond my wheelhouse to recommend what those behaviors are. But as a communication expert, I need to know what those behaviors are to start helping make plans to communicate efficiently, both in a crisis state and in a steady state. And so I think because of all of these challenges and all of these concerns, as well as sort of the lack of prioritization of communication strategizing specifically. It's not just about valuing communication. It's about actually, putting in the resources to engage in communication planning. I think because of those things, it's always challenging to communicate about antimicrobial resistance and stewardship across sort of animal, human, and environmental health. But there are some unique challenges to animal agriculture that could be addressed with that additional planning and specification of recommended behaviors. So thank you. And the last slide just says thank you. And so I appreciate the time and happy to end just a little bit before the bottom of the hour.
Thank you, Dr. King. We'll just hold all our questions till all the panelists have presented. So let's go ahead with Katie Capers from the CDC. Communicating antimicrobial resistance with the public. Katie, thank you.
Thank you, and thanks for having me. Can you guys hear me okay?
Yes.
Thanks. Hi, I am Katie Capers. I lead communications for antimicrobial resistance at CDC. In my normal job right now, I'm on a detail as the Acting Associate Director for Communication in the Division of Healthcare Quality and Promotion. When I'm working with AR, I get to lead the very small but mighty team that brings you things like the AR Threats Report and the COVID Impact Report that came out this summer. Next slide, please. I'm going to talk to you all today about some quick updates from CDC and how we've communicated to the general public on antibiotic resistance lately. I'll share some formative research from our partners at Porter Novelli, as well as an overview of some of our latest strategies and tactics, especially amid the pandemic, and then what's next on our radar moving forward. Next slide, please. All right, so what we know, I'll share some data here from our partners at Porter Novelli who conduct nationally representative and convenient surveys. Some of these range from 500 to 6,000 participants. We also have some data here from in-depth interviews and focus groups. This is kind of a mixture of data from multiple different surveys, so they're not all apples to apples, but we use these as snapshots to see what the Gen Pub is thinking about AR, about antibiotic use. So the good news is that U.S. consumers in general have a good understanding of AR and antibiotics. In one of our surveys of about 500 people, we saw that a quarter understand that AR refers to germs developing resistance. And since 2015, in one of the larger surveys of about 3,500 people, we've seen that a continuous and positive shift in understanding that any antibiotic use impacts its future effectiveness, which we know is critical for changing behavior change. In one of our surveys with companion animal owners and folks who are at risk for drug-resistant gonorrhea, we know that half are familiar with the term antimicrobial resistance. And in a survey with Spanish-speaking Gen Pub, I believe this is about 3,000 people, we saw that 72% know to only use antibiotics as prescribed. Lastly here, what you'll see is since 2020, and not surprisingly, more people are correctly identifying illnesses that antibiotics can treat and are correctly identifying infection risks of healthcare and travel. I think this has occurred likely because of just the global understanding of how germs spread and what puts us most at risk. Next slide, please. So of course, with all of that, we do have some improvements and gaps to close. I mentioned before that we saw about a quarter of folks know that germs develop resistance. We do have data from 2017, though, that shows that 66% of people think that it is people who develop resistance. In another survey, most recently in 2022, that number's gone down a little bit. 44% believe that people can develop develop resistance to antibiotics. And we do see in that study as well that this misunderstanding crosses over into beliefs about companion animals. So people think their dogs, their cats, their pets at home can develop resistance because of previous use of antibiotics alone, and not because of germ spread. Third item here is a newer phenomenon that we're starting to see in the data, that despite awareness and general awareness of the issue of AR, that people think that a third of the folks believe that AR refers to something that is protective or some sort of disinfectant. So you'll see a quote that we pulled from this survey. Someone said, "A product with AR helps to prevent the spread of germs. They're commonly found on phone cases and other surfaces and supposedly reduce the amount of bacteria that grow and live there." Obviously, some gaps to close in that knowledge. Lastly, I'll highlight that in one of the larger studies, we saw that 9% of participants reported saving antibiotics for a recurring infection specifically, and that 7% saved them in case of emergency. And we'll unpack that a little bit more on the next slide. And then lastly, of course, across all of our surveys, unfortunately, we're seeing varying disparities in knowledge, attitudes, and beliefs across races and ethnicities, and as a CDC priority are working to close those in the years to come. Next slide, please. One factor, and I'm not sure if this is surprising, but we see it consistently across all surveys, is that education is one of the most significant predictors of someone understanding what AR is. So in a survey that Porter Novelli conducted among parents, those with bachelor's degree or higher understood that any use of antibiotics now could affect how they worked in the future, which is positive. But I think, the disparity there is that those with less education or in other education categories are not making that connection. And we have to presume that parents are making antibiotic prescribing choices, infection control choices for their kiddos or dependents. And so that is a knowledge gap we've got to close. In a separate survey, so this is not among parents, this is just all Gen Pub. In 2021, we saw that as education increases, the knowledge of AR increases, correct knowledge of the relationship between antibiotics and COVID increases, which is that antibiotics are not effective on that virus. We see increased motivation to practice safe behaviors, as well as knowledge of what those safe behaviors are. And then finally, we see an increased understanding of how vaccines relate to AR and how vaccines can help turn the tide on antibiotic resistance. Next slide, please. We do have data from our longstanding educational campaign, Be Antibiotics Aware. Wanted to just highlight some things that we know work well. We continue to see positive feedback and engagement on social media, especially with content like the chart here to the right that is very easy to read and very actionable when you need it. This chart here is our viruses versus bacteria chart and shows which illness antibiotics are effective on. We also create through this campaign tailored materials to specific audiences. And I know this morning I heard folks mentioning the need for tailorable materials, and this campaign has that. We create partner packages for different settings so that folks are creating messages that are accurate, but also reflect what they need at the local level. And then we also know from this campaign that consumers are seeking antibiotic information, not surprisingly, from their doctors, healthcare providers, pharmacists, and then also Google and WebMD. When we look at things that don't work when we're communicating to the general public about antibiotic use, stock imagery does not work well. We have plans over the next year to do a photo shoot to get some more relevant modern photography done that we can use in our materials about antibiotic use. And we've also found that programmatic ads do not work well. We have seen a lot more engagement with our website and traffic to our website from paid media, and there's speculation of really just the size. Paid media gives us more space and we can pull people in better. We did end up updating our antibiotic use messaging during the pandemic, of course, emphasizing that antibiotics do not work on viruses, updating this chart, like I mentioned, it's very popular and so much needed. And we also increased posting on our CDC channels and with our partners to make sure that folks understand the relationship between antibiotics and COVID, especially as we saw potential antibiotic drug shortages in the fall. Next slide, please. Last slide here on kind of things that we know and have learned from our formative research. I know we've talked about this a lot today, but continuing to hear about mistrust of the government and even some of the healthcare profession. I'll just highlight this first quote. Someone said, after 2 years of government official and CDC misinformation, it's going to be hard to plead next reasonings for any vaccine. We continue to hear and have heard this since some work done in our educational effort for Be Antibiotics Aware, that folks have financial concerns, and that that translates to poor behavior really with saving antibiotics. So low-income family, the quote here is, we do save antibiotics because we're a low-income family and can't always afford to go to the doctor, so we save them for when we're sick, or I can't get off work to go, or I can't pay the office visit, so I just save them for the next time and self-prescribe. One last thing I want to highlight is personal responsibility. We don't see a lot of that in our themes. You know, CDC is consistently identified as the agency that's doing the most in this effort, and I think that people translate that to they'll take care of the problem. And so they have said that AR is the responsibility of scientists and medical researchers, which is really hard when you're trying to change the behaviors of the general public. This kind of not my responsibility mentality pervades a lot of our research. The last thing I'll flag here is the too big of a problem. It's already too far. It's a lost cause. I can't take any action. My action won't have any impact. We see that as well. Next slide, please. So what we've done, obviously we've got some gaps to close and are eager to do so, especially as the world is ready to talk about things other than COVID. So one thing I always try to emphasize is that we do not communicate about antibiotic resistance as an issue that only happens in healthcare. We always communicate about it across the One Health spectrum. So it's a problem, Gen Pub, in your animals and agriculture, in your food, environment, as well as community. So that's issues like drug-resistant tuberculosis and drug-resistant gonorrhea. Next slide, please. This slide is probably an oversimplification of the work that we've done, but I know we're tight on time. One thing that is not listed here is that prior to the pandemic, I think a lot of our AR comms team's work was very much focused on communicating to decision makers and partners to help ensure that AR was a national priority and remained a national priority. We did tap into the Be Antibiotics Aware campaign to communicate mostly with consumers with the intention around 2020, after the AR threats report was launched, to really pivot and focus more on our communication with the general public and the actions that they could take. Of course, the world changed and we had to change our strategies with it. And so we leaned a lot on some new tactics and the old stuff that always works. So, of course, we communicate regularly with media and health departments, making sure that local audiences are aware of AR-related outbreaks, especially as they relate to food and healthcare, what they can do, how they can stay safe, and what information we have now and what we can share later. During the pandemic, we also launched our first AR-specific social media handle on Twitter at CDC_AR. I might not have this data point quite right, but I think, in an external assessment that was done, I believe we scored at the top, like 94% of the agency's social media handles, scoring well for plain language and making sure that we're communicating quickly to our audiences and getting them the information that they need. We recently reworked the drug resistance website. We rewrote more than 50 pages of materials so that it would be in plain language, especially for our Gen Pub audiences, and made a new section of the website that is specific to the general public. The last thing I'll highlight on this slide is we are shifting. You probably have seen this from us in the last year, but shifting to using antimicrobial resistance, even though I've probably said antibiotic resistance on this presentation a lot, because we know that understanding and using consistent terminology helps to change behavior. It helps create that knowledge base. And so we have shifted to that along with other partners globally. Next slide, please. Wanted to highlight a few things from the Be Antibiotics Aware campaign that they have been able to accomplish since their rework in 2017. I'm not going to go over all of this, but we do place a lot of paid media ads and have a lot of materials, again, that are tailorable to certain settings or certain audiences. Since 2017, they have reached more than 480 million people with public service announcements. They have reached more than 136 million people with paid media. And then if you go down a little bit, you'll see that we've gotten and driven more than 37 million people to our CDC antibiotic use website, where we have seen heavy materials download and use over time. Next slide, please. So what's next? This is the part that I'm really excited about. As I mentioned, the world is ready to hear, I think, about another topic. I think we have to be creative about how we frame it. But we do have plans that have started in the fall and will really be kicking off in the spring with our Be Antibiotics Aware and sepsis campaigns. So we are doing a pretest in geographies where we see high antibiotic use and high cases of sepsis and C. diff of knowledge, attitudes, beliefs. Then there will be a very large media run in those areas, and then a post-test of those audiences to see how our campaigns might be impacting knowledge, attitudes, beliefs, and then even better identify what gaps we can fill with our messaging. We're also in the throes of an assessment to determine if a domestic or global AR campaign from CDC could be effective and beneficial with our audiences. We are testing some new materials and creative that reframe the issue of AR for our audiences, so emphasizing things like personal responsibility compared to AR being a societal problem, kind of akin to climate change. Of course, this is not, we do not have approvals for this campaign. A lot of paperwork is needed for that. But we want to make sure that we have the justification in place before that is started and if it is needed. But of course, it will only be successful if we have collaboration with our partners who are already trusted by audiences, especially given what our formative research is showing us. We're going to continue to refresh our Be Antibiotics Aware materials and pushing that prevention messaging that you saw from us last summer with the COVID report. I think a lot of the misconceptions that we continue to see in formative research are that people think a new drug or a researcher will save them from AR whenever it arrives, and really what they need to be doing is some really practical prevention steps that we can take today that will help us in the long run. Lastly, of course, we are always seeking additional resources and partners who can help us to scale up this messaging, but we are always appreciative of partners who use what we're sharing with them already. And last slide, please. I hope everyone will go follow us on Twitter. It's at CDC_AR. If you're not already, we do share a lot of the latest information from the agency there, as well as in our listserv listed at the bottom. Thank you for having me.
Thank you, Dr. Capers. Our next speaker is Megan Davis from Johns Hopkins University, communicating AMR, One Health Small Animal Perspective. Dr. Davis.
Great, thank you so much. It's wonderful to be here. I'm Dr. Megan Davis. I'm an associate professor of environmental health and engineering and have a background as a mixed animal veterinarian. I also happen to direct a new total worker health center in mental health where we think about a lot of One Health workforce development. So I think that has a role here. Please advance. Just want to have a land acknowledgement that our campus resides on the unceded lands of the Piscataway and Susquehannock peoples. Next slide. So I use a One Health perspective in a lot of my thinking about AMR and AMR communication, and this is kind of the classic example of the Venn diagram of One Health. Next slide. But I think, back one, great. But I think when we look at the Venn diagram, we see the area where they overlap, and that's what we term One Health. But we also have a lot of programmatic activities and communication strategies that fall only within one of the domains. And when this occurs, I think we have a lack of shared responsibility to address the challenges and potential disconnect with our communication strategies. And so it may be important to move us towards more integrated messaging that really engages all of these domains. And within environmental health includes not just aspects of the built environment, but also plant health explicitly. Next slide. This is a really complex science, as Dr. King alluded to, and so I just have a quick motivating start for us so that we have a concrete example that really focuses on vulnerable populations that I want to highlight in this chat with you today. So coming from an environmental health perspective, I think about how different environmental media are important to exposure of our human and animal hosts and how we might have intersections between the infectious agents in the environment and various chemicals, including antimicrobial drugs. Next slide. And so to illustrate this, we might also have a system that has feedback loops that, again, are really complex and can be important to consider in communication and messaging. And so if we have exposure to an infectious agent, next slide, we might use antimicrobial drugs, which can create selective pressure, not just within the host, as we heard in our prior talk, but also within the environmental reservoir. Next slide. And so when I think about this, I just want to give you a focus case so we all have something kind of concrete to talk about. I've done a lot of work in inner city communities looking at antimicrobial resistance within particularly methicillin-resistant Staph aureus. And we think about this over time as a concern from a One Health perspective because an individual who has MRSA may shed MRSA into the home environment. Next slide. And then that can be a reservoir for re-exposure of that prior infected person, household members, and companion animals in the house. Next slide. And in our own work, we've seen that this can also be really a risk factor for exposure to multi-drug resistant strains as well. And we see, unsurprisingly, that human and pet use of antimicrobial drugs can be associated with MDR-MRSA, but also conversely that we get some really unexpected relationships. And whether these are due to reverse causation or these are really true really remains to be unpacked. But we've seen some association between uses of disinfectants in the home that are supposed to be effective against MRSA and increased MDR within the MRSA strains that we identify. And so really getting to the bottom of this and understanding these complexities on a molecular level in terms of co-selection and perhaps genes for resistance to other chemicals, not just antimicrobial drugs, is going to be an important part of our strategies. Next slide. And of course, we also think about, and I think COVID has really given us an opportunity to use AMR as kind of our all hazards preparedness for communication strategies, since COVID-19 and methicillin-resistant Staph aureus are both reverse zoonoses. So we recognize that our companion animals are likely exposed from an infected household member, and that there's still potentially the opportunity for them to be a reservoir for re-exposure, but they also may be more important as a sentinel or canary in the coal mine, so to speak. Next slide. And so when we think about the various things that can drive drug resistance and pathogens in our companion animals, this also can be a very complex pathway and can intersect with some of the important factors that we're looking at from a human health and public health perspective. Next slide. And increasingly, this can include exposure to drug-resistant pathogens in the environment. And these are just data from that same study of MRSA-infected patients who were primarily inner city or rural residents, low income. And we saw that when we looked at the pets, they tended to carry the same methicillin-resistant Staph aureus strains that were found in the environment, and that we had, by and large, relatively high concordance in terms of the patterns of antimicrobial resistance. Next slide. So what does this mean in terms of our communication strategies and what we may need to do to help really expand these and shore these up? And a lot of our One Health infection control interventions are based on, human and veterinary healthcare settings and a focus on manual cleaning or no-touch technologies to help to reduce risk of transmission, or maybe around stewardship programs in both humans and animals. Next slide. We also may communicate directly with veterinarians. In this case, I'm using an example coming out of the MRS, the methicillin-resistant staph, where we have guidance documents that are meant to guide best practices for clinicians in their treatment and management of individual cases in when we have animals, companion animals that are infected with methicillin-resistant staph. Next slide. But I really think we have to consider communication strategies from a more structural level. And so if you think about risk communication and our communication strategies as being part of the triad of risk assessment and risk management, I think we need to think about communication in a very bi-directional way. This isn't just what we're pushing down to the public. This is also how we have a lot of interface among the various levels of communication, whether these are in our classic global health security agenda related agencies, the World Health Organization, FAO, WOA, and UNEP, but at the national level, at the subnational level, and then how those may interface with various other stakeholders, particularly our frontline workers and organizations in human healthcare, veterinary healthcare, and animal care writ large, and how these then also interface with our academic institutions and organizations that may be working to address those gaps in terms of scientific evidence, helping to be experts in the promulgation of guidelines and best practices, and how then all of this interfaces at the community or public level. Next slide. We know that veterinarians may be a really important asset in our communication strategies with the public. There have been a number of different surveys that have looked at public perceptions of veterinarians. I remember there was one that came out when I was just graduating from veterinary school in the late 90s, early 2000s. And here's one that was just published in 2020 that showed that in general, there is a more favorable public perception of veterinarians compared to physicians, where those surveyed indicated that they found veterinarians very approachable, sensitive, sympathetic, patient, and understanding, and conversely found physicians somewhat proud, arrogant, or overconfident. Whether you agree with these findings or not, I think it points to the fact that veterinarians may be a trusted source of information, and trusted sources of information can be absolutely critical if we're thinking about behavior change. Now, notably, this study was performed prior to COVID-19, and we recognize that COVID-19 has really changed a lot of public perceptions around who are trusted authorities, in what ways are they trusted, and what are the avenues of misinformation and disinformation that can help to erode that trust. Certainly, though, I think veterinarians are a group, right, that we can target in terms of our communication strategies, because unlike some of the other public health officials who've really seen kind of that hero to zero landscape in terms of public trust, I think that there still remains a lot of public trust in the veterinary perspective. I also think that we should think about this not just among veterinarians, but all of the allied health professionals on the animal care side. Next slide. So we did a study of a lot of veterinary and animal care workers, and we actually did this in both the US and in Peru. I'm going to focus on the US here. This was in the early months of the pandemic between July and October of 2020. And among the things we queried were communication and knowledge sources. So again, not necessarily thinking about veterinarians communicating to the public. We did ask them other questions about their public interface, but we were most interested in how information and knowledge were being disseminated down to them. Next slide. And as you can see, we had 75% or more of our study population were in the small animal field, whether they were veterinarians, technicians, assistants, or support staff. And we had an additional 8% who worked in animal shelter or control. Interestingly, we found that there was a lot of diversity in the various avenues of communication to these various stakeholders, and it varied by job role. And we even saw that there were different sources of information that were used for animal shelter versus animal control, for example. And I think what this highlights is a real need to think of this from a systems perspective in terms of integrated communication strategies and using AMR as the day-to-day activity where we should have communication that then may be leveraged when we have crises and more emergent needs, whether those are related to something like COVID-19, where we have a spillover event in a global pandemic, or if there are other kinds of crises, for example, in disaster settings. We did ask about disasters. We're still looking at those data within the COVET study, so I hope to have more published on that soon. Next slide. I think also from a systems perspective, this means that we may need to think about roles and responsibilities at many different levels of communication and governance. So if we think about animal health and how it's located at the national and subnational levels, most of our animal health departments, right? If you think about the United States Department of Agriculture or a state level Department of Agriculture, do have some roles for companion animals, but you see most of the focus is on agriculture, and that means food producing animals more so than pets. And environmental health ministries, agencies, et cetera, also are typically a little bit more limited in their expertise or scope for infectious diseases and AMR. And so if they are playing roles in communication, there may be limitations to the kind of expertise they can bring, and they may need to lean more heavily on other kinds of stakeholder groups to aid in these communication strategies. And so again, thinking of this from a very integrated perspective and thinking about bi-directionally the lines of communication among these different levels will be important. Next slide. And I just want to wrap up by talking about how we have other kinds of less traditional stakeholders we could engage in communication strategies. I think COVET, for us, our data pointed to a need to really engage in animal shelter and animal control workers, because they really had a lot of motivation to be of assistance, and I think that they can also help us to reach more vulnerable populations. Veterinary services really may not reach all members of the public who own pets. In our study of MRSA in households, we identified that only 30 to 40% of companion animals, these are primarily the mammalian species. I can talk about the non-mammalian pets at some point. It was super interesting to see how many of those there were, but only 30 to 40% of those dogs, cats, and other pets more likely to see a veterinarian had been to a vet in the prior year. And we even saw some differences according to our groups. And so where we had 30% of pets who lived in a household in which the index patient was Black, we had 42% who had reached a veterinarian in households where the index patient was white. So there may be some disparities there. And we also recognize that there are whole areas of the country where there are pretty extreme veterinary care deserts. And I'm sure Dr. King and I can also talk about a lack of veterinary services for food producing animals in certain regions as well. And so we may need to really go into these alternate groups like animal shelters in order to achieve the messaging goals. Next slide. And so, again, I wouldn't say these are conclusions. These are some of my thoughts on this topic, is that we really need to be diverse in our engagement of stakeholders, really go beyond certain kind of expected individuals into other trusted authorities and individuals who may be able to help us reach these vulnerable populations, and also to address some of the structural gaps and really try to harmonize some of our strategies so that the messages that are coming through on many different fronts and to all of the various audiences we may want to reach. And with that, I'd like to thank you for your time. And if you have any questions, please feel free to reach out to me, not just during the Q&A, but also you can reach me by email. Thank you.
Thank you, Dr. Davis. It sounds like we might benefit for a All Creatures Great and Small series for physicians, according to your survey. So, all right, our last speaker is Dr. Aisha Langford from NYU Langone Health, addressing antimicrobial resistance, health literacy, communication, and decision-making considerations. Dr. Langford.
Okay, thank you for having me. Can you hear me okay?
Yes.
Okay, you can advance the slide. So I wanted to start this presentation with one definition of health literacy. If you all have been following the health literacy research for the last 20 or 30 years, you know there have been several definitions, but this one is from Healthy People 2030, and they define personal health literacy as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Next slide. Healthy People 2030 also puts forth the notion of organizational health literacy, and that's the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. And I just wanted to highlight that the Healthy People 2030, if you go to the website, some of the changes that they made with these definitions were really to emphasize people's ability to use health information, whereas prior definitions talked about helping people make appropriate decisions, but also focusing on helping people make well-informed decisions. And then also with regard to organizational health literacy, really putting a public health perspective on these definitions and also distinguishing that it's not just the responsibility of individuals and people to find and use health information, but that organizations also have a responsibility to address health literacy for the public and patients within their health systems. Next slide. So in 2020, I actually had the privilege of publishing a paper in the European Urology Focus Journal. And I had the privilege of writing this thought piece with a urologist, a medical librarian, and 2 research assistants who were in graduate school. And in that paper, which was focused on the impact of the internet on patient-provider communication, we talked about different ways when people are out in the world online and finding information, ways that we can help support helping people find reliable and vetted information. And one strategy that we talked about in the paper are the 3 R's. And that's the idea of when people come in, say, finding information about antibiotics or why they want to take a particular antibiotic, that we really have the responsibility as clinicians to reassure patients that maybe what they've found or that their condition that they've read about may not necessarily apply to them, but also to acknowledge and explore their reasons why that particular article or information they thought that it applied to them. Another strategy is to redirect, and that as healthcare professionals and public health professionals, we have a duty to redirect and steer patients toward medically verified sources. And then finally, when appropriate, it may be important to refer patients to a multidisciplinary team to help meet their needs. We also talk in that commentary about the importance of having curated list of reputable sources to recommend to patients. And so the earlier presentation on the CDC's Be Aware of it, the antibiotic Be Aware campaign was one really great resource. But in that paper, we talked about curated list, and in this case, curated list of reputable sources of urology information. And you can work with medical librarians or other health educators to help create those lists to make those available for patients. And then finally, in addition to CDC and other great resources, we talked about the value of medlineplus.gov as one potential entry point or starting source to help patients find information. And Medline Plus, for those of you who don't know, it's actually managed by the National Institutes of Health and the National Library of Medicine, and has really excellent resources around a variety of health topics, both in English and in Spanish. And it's really meant to be a trusted source of information in plain language. Next slide. So one example of an entry on Medline Plus, this one is, as you can see, focused on antibiotics. And they really talk about, very simply, what do antibiotics treat and in what situations antibiotics may be helpful. So in bacterial infections, and they give examples. And then they also talk towards the bottom about what antibiotics do not treat and how they do not work on viral infections. And in addition to pictographs and other visual displays, for some patients, this may also be helpful for patients that like to read or go online and find information themselves. This is, again, one example of where you can help direct patients and actually friends and family. Next slide. Another strategy that I research a lot and talk about in my academic circles are the idea of shared decision-making. And so many of you have probably heard that term, but it's really a communication process by which patients and clinicians, and sometimes families when the patient wants the family and friends to be involved, work together to make optimal healthcare decisions that align with what matters most to patients. So sometimes that's articulated as patients' values and preferences. Next slide. So shared decision-making is not one thing, it's really a process. And so some of you may be aware of the SHARE approach, which was put forth by the Agency for Healthcare Research and Quality. And their SHARE approach stands for, the first step is seek your patient's participation. The next step is to help your patient explore and compare treatment options. The third step is to assess your patient's values and preferences. The fourth step is to reach a decision with your patient, and then hopefully there will be some type of follow-up. And the fifth step is really to evaluate your patient's decision and how that decision process is going. Next slide. So there are many, many ways to support shared decision-making. One of the more published ways are patient decision aids, but there's also many other strategies. So this is a screenshot from the Ottawa Hospital, and that's a group out of Canada. And they actually have a inventory of various decision aids. And so I just wanted to share this if there are clinicians or even public health professionals listening in, that this is another resource to share with the public. I happen, as you can see in the top box there, I just happened to put in antibiotics, and there were 4 patient decision aids that came up, one related to bronchitis, ear infections, lung diseases, and sinusitis. Next slide. And so for those who are not like me and aren't used to looking at decision aids quite frequently, on the Ottawa Decision inventory page, I'm looking at the one that's focused on ear infection. When you click on those links, it'll tell you who the audience is, what the options that are included in that particular decision aid. So for example, in that particular decision aid, the first option would be to wait and see if the ear infection clears up on its own for their child, or to give antibiotics. It also gives the year that that information was published. And if you click on the decision aid, it'll run through a list of facts, pros and cons, and exercises to help the patient or the family member help identify their values and preferences for the options presented. Next slide. So in my last few slides, I want to talk about clinical trials. So one area of research, in addition to health communication and medical decision-making, that I study are clinical trial participation across demographics, but for me in particular, I'm very interested in racial and ethnic participation in clinical trials and also older adults. And so many of you are very familiar that there's lots of types of clinical trials, phases of clinical trials, and targeted audiences. And as we are talking about antibiotics and antimicrobials, it is really critical to continue having effective and new antibiotic drugs for humans and animals. It's important, well, we're talking about humans right now. It's important for people to know about clinical trial options and to be involved if that is a good decision for them. Next slide. This is a general model of clinical trial participation that I had published in the Journal of Health Communication, and this was actually in a special supplement focused on vaccine clinical trials. And I'm not going to go over this whole graphic here because it has a lot of bullets, but I just wanted to reiterate and remind some that participating in clinical trials, from the person knowing that it's even an option and considering it to actually enrolling into a clinical trial and finishing it, there's lots of steps in between. And we as researchers have to pay very close attention to the patient characteristics, and in particular health literacy and sociodemographics. But also in that top box, we have to be very mindful that the clinical trial characteristics and the decisions that we make early on as researchers and study teams have implications down the line around who can participate in trials, if it will be perceived as too burdensome, how much of a travel burden they'll have, and what's acceptable. So it's really important for us to think about that early on, and whenever possible, integrate patients and perspectives of the public early on in the idea phase so that we're not surprised down the road when we can't enroll people. Next slide. So hopefully everyone on this Zoom has heard about clinicaltrials.gov, but many of my family and friends before I started doing research weren't necessarily looking for clinical trials online. And so clinicaltrials.gov is one resource. And a couple of weeks ago, I actually was just interested to see what type of antimicrobial agents and trials were open. And so this was an example of a search that I did on January 11th. And the search yielded about 1,600 different types of trials related to those search terms there, recruiting across the lifespan and NIH and industry funded. So it's just very interesting. And again, I think part of the conversation that we don't really have as much is like, how do clinical trials contribute to this conversation, and how do we promote clinical trials around antimicrobial resistance and antibiotics in general? And then also on the other side, how do we communicate those results? Next slide. And then finally, my last slide is really, as many of the earlier presenters talked about, that I think we should think about this as reframing choices. So as we're talking to patients and the public about antibiotics, we don't want to give the appearance that we're trying to withhold something that's very helpful from people, but we really want to really frame these choices as what is going to be best for the patient and the family situation. And often there's lots of strategies and tools that can be used, and we want to use the most effective thing first, always knowing that we have other tools in our toolkit. And so hopefully this will be a good jumping off point to have continued conversation in the next portion. And I think that's my last slide. Thank you. I appreciate it. And feel free to reach out if you have additional questions or thoughts about this presentation. Thank you.
Fantastic. So I see there's already a hand up. So we'll start with the council's questions, and Dr. Blazer, start us out.
Well, I'd like to, thanks, Elaine. I'd like to thank the presenters for really educational material. I'm always educated by what people say, and today's education deals with something that I would never have thought of in a million years, and that is that the public might be confused about the term antibiotic resistance. That's our mantra. That's our sacred cow, or AMR or AR. But of course, resistance has a different meaning. During World War II, the resistance, that was a good thing. And, when we talk about people's not getting ill, we say they have a lot of resistance. And that's a good thing. And so we're using a term, our central term is a term that is inherently confusing. And I wonder whether we should look for some new terms. That's dramatic, but that's why we have these meetings. Going forward, I mean, the concept is not about resistant bacteria, which is ambiguous, but maybe it's something like bacterial escape, bacterial jailbreak, bacteria run amok, bacteria out of control. You can see I'm not a linguist, but other people may have better ideas. But I'd just like to ask our panelists and our council members in general to think about other ways of rephrasing this problem.
Yeah, thank you, Marty. I had the exact same question and shock that 9% or about a quarter of people didn't know that antimicrobial resistance related to germs. I mean, that's just shocking. And the other thing that was shocking in your report to me was that only 9% reported saving antibiotics, which I'm sure is not the case. It's probably much more than that. But have you given some thought, Katie, and the others to renaming?
We have. We've heard this from a lot of partners actually in the past, especially as we start to see the data. The assessment that I was referring to at the end, that will be part of the conversation and part of the assessment. Like, what other ways can we describe this, and how would our audiences describe the issue back to us if we were to ask them that? But I think back to my original statement about how we're shifting to antimicrobial resistance and not antibiotic resistance, it's only going to be effective if we all shift. Otherwise, we're just going to use competing terminology and continue to confuse folks.
Thank you. And David put in the chat a suggestion of decreased susceptibility. So let's call on Dr. Apley.
Hi. Thanks, Elaine. Yeah, thank you, everybody. Oops, yep, I'm good. For your presentations. One of the things listening through the day today is I've noticed we really focus appropriately on getting correct information out there, putting the real facts. But is there a place to get down in the mud and wrestle with those putting out the disinformation? And I go back again to the ivermectin for COVID craze, and especially in the agricultural area where it's a readily available over-the-counter product, and many people were advocating its use. Should we not only have the component of here's the facts about vaccination or antibiotic use, but also actively push back on disinformation?
I can jump in, although I'm not a communication specialist. We do have some faculty in our Center for Health Security who've been working on trying to think about communication countermeasures and how you can intervene. So I think this is still, at least in this space, perhaps a little bit more of a nascent area of inquiry. But I certainly think that identifying different ways, and I think finding trusted members of the community to also serve as our spokespeople will help, because if some of the misinformation and disinformation erodes trust in your standard public health authorities, then you need someone on the non-standard side who can potentially step into those roles as needed.
So, Dr. While you're speaking, you actually put a really interesting link to an interesting paper. Do you want to make a comment about that?
Yeah, I was part of a group that was led by Stephanie Lansing that was thinking about communication and AMR, and we actually did text data mining within various scientific publications to look at how language around AMR was used among different fields, and found that actually there's a bit of disconnect. And so even among ourselves, we don't actually always use these terms in the same ways, coming from different perspectives. So you may have a little bit more of a homogeneous approach within maybe certain human clinical settings, but that may be very different from how you see those words used within the environmental AMR community. And I think that being able to reframe our language and try to make sure that we are using terms in the same way is going to trickle down into more coherent communication strategies, because we're all going to be coming from the same place of understanding.
I mean, if it's all right, I'd like to just have a few thoughts on these two matters too. I think rebranding a large health concern like this, that ultimately is not one thing, is going to be a challenge. I think just in general, obviously, and I think someone linked the Welcome report that also gets into some of the sort of inconsistencies of talking about this topic, and I'll say this topic to avoid a preferential term, I guess. But the other thing that sort of came up in this most recent question was about this idea about battling misinformation and disinformation. I just think it's important to acknowledge that sometimes people aren't misinformed, they're confused. And we have a lot of focus on misinformation and disinformation because it's the thing that we can feel good and active about. And we want to go combat, and there's bad guys do it. And the reality is misinformation, and the people who are accepting the misinformation are still generally a small percentage of the population. And if we focus too many efforts on them, we're missing the 90% of the population or more that's interested in having clarification and understanding what's happening and potentially responding in a way that's helpful. And so I say this as someone who works in communication and works with misinformation and sits down the hall from someone who's done a lot of work on political misinformation and correction and things like that. And those things are important. I'm not meaning to discount their importance, but to sort of focus on that, I think, is to take an easier route than the actual challenging route of saying, how do we go about putting out information and communicating in a way that resonates with the public? Because I don't think it's about just getting the facts out. I think being clear is important, but it's not just about the facts. That model's never worked in science communication in the history of science. It's never just worked. We're not pitchers to fill up. We don't just get the right information and make the right decision. If it was, I'd be running marathons on the weekend just for fun, because I'd be super healthy and doing all of the things I'm supposed to be doing. And I'd never drink a beer, and I'd never smoke a cigar, and all those things that I enjoy so much, I wouldn't do any of them because they're terrible for me. But just because I would know that they're bad for me, and why would I do it? And obviously humans are more complex than that. And particularly about this topic, I think something else that hasn't been discussed too much today is that people don't care about this. The general public doesn't care about it. Some of the stakeholder groups we're talking about are very concerned about this. Everyone on this call is very concerned about this. But when we talk about the general public, even when we ask them about it, if they care about it, they're responding to us asking them about it. They're not responding that they care about AMR in the list of possible health and wellness concerns in their lives. And there are people facing greater health disparities that have nothing to do with AMR. Not that AMR is not important to those, as was brought up in multiple presentations today. But I think that I want to complicate this further in this Q&A and say that what we talked about today was a good overview, but it barely scratches. Because again, I do animal agriculture stuff because I worked at Iowa State and we had a vet school, but I also do cancer stuff. And I edit a journal on health communication. And so all of these things together, I just want to say, like, the communication thing's even more complex than the hour of presentations we had today. And I just want to make sure that we're very clear about that as a panel, or at least I want to be clear about that as a panel member today, before we get too deep into some of the Q&A, Q's and A's, and A's that will be incomplete. So I'll mute myself so other people can talk.
Oh, thank you, Andy. Do any of the other speakers want to respond to that before we move on?
I would like to. One thing that, of course, addressing misinformation and disinformation is a priority for CDC, has been a priority. I will say there at the agency has been a reconsideration of our social media strategy and an overhaul there, and we're able to respond back to folks that are spreading misinformation or disinformation and correcting that information, so that if folks are scrolling comments, they at least see the accurate info. Again, to his comment that, like, the accurate info is not necessarily going to be what makes the behavior change.
Okay, Dr. Craig.
Thanks, Elaine. And I just want to thank Katie for her presentation. Katie, for folks who don't know, has been working behind the scenes on AR communications for many years. Most of the presentations that you've ever seen given by a CDC person, like the dozens from Arjun Srinivasan, are really because of Katie and her team's work. So I just want to flag that for her collective unsung hero-ness, as well as that of her team. She's been a great inspiration. And I think the other thing about this is I wish we had collectively hundreds more of Katie, that we could clone her to do some of this, because I think, as she noted and as Andy noted, the complexity of communicating on a topic like this is so much more sophisticated and challenging than at first glance. I think a lot of us underestimate the challenges of that. And we underestimate the very simple things, as Marty noted, right? We think, oh, well, we can just communicate to the public on these things. But when we just look at our terms of antibiotic, one, people don't know what an antibiotic is versus an antibacterial versus an antimicrobial. And then the question of resistance. People are understanding these things different. And there's so many different ways of doing it. Now, that doesn't mean we give up, of course. And I think a lot of this conversation is important. But I think I would totally agree that this is sort of scratching the surface. And it's also an area that needs intense resource. Like a lot of the things that Katie noted in terms of the surveys, we've invested a lot in trying to just get an understanding of where people are and where they're coming from. Just a baseline of understanding so that when we put out a message, we're trying to understand, well, are they actually understanding the message that we're putting out, or are they understanding something completely different? And as we noted, that sometimes they are understanding it completely differently. And I think the other piece that's important here on some of the things that Katie noted is how do you educate folks and get them to care about things when the biggest concern that they have is putting food on their table? Or how are they going to pay for the doctor? Or how are they going to keep an antibiotic or tell them not to keep an antibiotic because they can't afford an antibiotic for their kid in the future? Like that is a challenge. That is something that I think we dramatically underestimate. And how do we have and tailor a message to try to address some of those things? Like we can't overcome all of those pieces, but tailoring the message to an audience matters more about what the audience is dealing with than it matters about what our message is. And how do we get them to understand it? So I just, thank you guys for pulling this together, and thanks to Katie, but just want to, really reiterate that this is always more complex than we give it credit for.
Yeah, so speakers, do you want to comment on that before we go to the next question? Dr. Plummer had an interesting, gave us an interesting chat reference. So, Paul, do you want to just point that out?
Oh, I can just comment. The reference is in there. That's a project that we worked on with Laurel Redding and a group of others, talking about, well as Michael Dahlstrom, who was a colleague of Andy King's here at Iowa State, looking at this point that Andy made related to, it's not as simple as just getting accurate information out, and the importance of underlying values and perceptions in the person receiving the message and how that's interpreted. And I think Andy did a great job of giving all kinds of examples, around different risk factors that there's, seat belts to whatever, seatbelt usage or, alcohol, smoking, all of those things where we know there's clear evidence, but not everybody just changes their behaviors because there's very clear evidence. And so reiterating that science communication is very complex, and that really the sociology of this, of those values, perception, influence the message reception.
Thank you, Paul. From my perspective and my research, hand hygiene is a perfect example of what we know and what we do don't match. So, okay, Julie.
Yeah, thanks to everyone on the panel. Again, a wonderful set of talks. My question emerged when I was listening to Dr. Davis's and Dr. Langford's presentations, in particular about the role of the healthcare workforce of, animal or human medicine workforce, in terms of Dr. Langford mentioned shared decision-making, and thinking a little bit, Dr. Davis, about your role in total worker health, and thinking a little bit more about what we know currently about the state of healthcare work environments, healthcare worker mental health and burnout, conflict with the general public, and how that intersects with them as sort of messengers to help sort of deliver this information to the public, and if there's something we need to consider, particularly around bolstering wellness and creating better work environments. This is something that came up in our September meeting. So I'd be curious if you had any thoughts about how that might influence communication. Thank you.
Great. Dr. Langford, do you want to go first, or?
Yeah, I think that's a great reflection. I think, I don't know, I guess kind of like Andy said earlier, when we figure that out of like how to fully integrate like shared decision-making and all the tools, I will say some health systems have been integrating patient decision aids actually into the patient portal where it gets like automatically pushed out. It's not a perfect solution, but for people like me or even family members who like serve as proxies or caregivers for their loved ones, sometimes it is nice to be able to have a understandable piece of information pop up in your patient portal, and I think that can be very helpful. I have seen in some places where like health educators and decision coaches are slowly and mostly in a research setting right now being integrated into like primary care settings and oncology settings. Again, that's not like a perfect structure, but I think many clinicians, in particular doctors and nurses, would love to do that, or not everyone would love to. Many people would like to do it, but it's time, right? When you go to your doctor, I mean, you don't have time to do the regular things you have to do in addition to having a full conversation and explanation about antimicrobial resistance. So I think that's another potential strategy to think about, but yeah, like different team-based approach, which I think is still really evolving. But I think if we can be a little bit more holistic about who's qualified or who can support communication and health education and who can kind of work at the top of their training, I think maybe in, I don't know, 5, 10, maybe 20 years, you might have a kind of a better way of serving patients and our clinical teams in help reducing burnout.
Yeah, I want to like give 10 plus ones to that, especially around team-based approaches, because we have to recognize that if we're thinking about engagement of healthcare workers and veterinary and animal care workers as really key trusted sources of information who are really critical to be part of this communication process, we also have to recognize the levels of burnout that we're seeing within these industries. And, you know, certainly one of the reasons I work in total worker health and mental health now is because of the high suicide rates and issues with other mental health challenges within the veterinary and animal care worker profession. And we certainly see that, you know, paralleled in many other occupations, including, of course, physicians. Depending on their roles, you can see higher or lower rates. So just to make sure everybody's on the same page, we're talking about being good and clear in our language use. Total worker health is an approach that was really started by NIOSH a number, like decade plus ago. Thinking about the workplace is not just a place where, like, I think about it, putting on my Wonder Woman gauntlets, trying to protect workers from all the hazards at work. It's also about this as being a place where we spend a lot of time. And so a place where we need to invest in well-being and invest in strategies that help promote not just individual worker health and well-being, but also organizational outcomes. So even thinking about how having a healthier workplace will empower better outcomes. And this can be better patient outcomes as one of the metrics within the healthcare setting. So that's just what total worker health is, and where the mental health piece comes in and where it comes into the communication side is understanding that we may not want to just like assign the responsibility and then expect that our healthcare workers can just add that in to the giant burden of clinical care and administrative functions that they have without harm. Instead, we should take a much more team-based approach, thinking about who can be the communicators, where do we need to put the trainings, what are the other supports that we want to put into place to help to empower our workforce to be the best communicators that they can be, but again, not just being that extra burden of something that they just have to do.
Thank you, Megan. Before we move on to Dr. Jinks, Julie, before we leave you, this morning, Dr. Srinivasan put in the chat that you should ask Dr. Capers, a question. Do you remember what that
Yeah, no, and I think we touched a little bit on it. You know, I asked in the first session about the role of the medium, you know, separate from the content of the message, and in particular, and I think all the panelists could potentially speak on this, the role of, we have so many different channels by which we can deliver information, some of which are designed in ways that are not incentivized to communicate information, but to amplify engagement by making content irresistible to stop looking at, which is not necessarily aligned with the goals of communicating accurately. So that was the question, and I think, you know, we've heard bits and pieces of it, but I don't know if now's the time if people want to talk a little bit about how the actual medium matters in terms of what we're talking about here. And I think seeing all the social media stats from the CDC about engagement with your messages was very interesting, and measuring that is clearly very important. So,
panelists, do you have comments?
Sure, I'm happy to kick us off on this. I think message and where you're putting the message is always going to be important. We have several systems at CDC where people can opt in to our messaging. Of course, that takes a necessary first step of them wanting that information. But we have Healthcare Action Network, or HANS, that we can disseminate information out quickly in case of like outbreak alerts. We also have the regular communication coming out through social media, and that can go more toward the general public. And then we can always pull that lever when it's necessary to have a spokesperson who will address media and news to make sure that the message is disseminated widely. One thing I think that always kind of crosses over into communications is also our partnerships. So we make the documents, the messaging, but then we prepare partnership packages that are then given to people who already have the ear of the listener. And so they might not hear it from us well, but they can use that material from a trusted organization locally who they're already interested in hearing information from. So I don't think this is a surprise to anyone. It's also about the messenger, not just the message, whenever we're communicating, especially about something that people have a hard time understanding.
Dr. Langford, Dr. Davis, any comments?
Nope, that was great.
Okay.
Agree. I'm not a communications expert. I'll just say that when we're talking about difficult to reach and vulnerable populations, that you may really need to think about altered strategies for communication. What we found with some food systems research, again, not related to AMR, is sometimes just a need to show up in the community and be present rather than try to disseminate something through a social media platform or other more generic service for communication.
Thank you.
Yeah. Oh, sorry. I was just going to comment on Medium real quick. And just that I think with social media, I think something that 10 years ago I would probably make fun of, and I regret doing so now, is that, you know, the rise of influencers as a category of people who are actually out there. I think that used to be sort of a thing that occasionally people would mock. And now I think it's something to acknowledge, at least in the current moment. It's something that actually those individuals on the various platforms that they're on, often social media and across social media platforms, do have a lot of reach. And can reach potentially even vulnerable populations depending on the influencer in question. And so that it could really benefit long-term the development of relationships between public health agencies, whether that's the CDC or other sort of more local state health departments, to sort of have those relationships to even just get a message out there quickly, and just sort of that dissemination component. And I would just mention also, when we talk about sort of metrics and things of interest, right, is that I would just encourage everyone to be very careful about ever using sharing as a metric, right? Because sharing is good and we want our message out there, but obviously we can share for all sorts of reasons. We share things sometimes to make fun of them, right? So it's by itself is not great. In concert with a bunch of other metrics, it's a wonderful way to sort of look at the impact. But that, you know, it's just something to consider as you're thinking about, like, oh, look how many times it was shared, right? I'm sure there are a number of incidents that have happened over the past month, for example, that we could look at, and I'm sure there are people who would prefer they had not have their message shared anymore. But anyway, so yeah, I just think that the influencer thing is worth bringing up, because as goofy as it is, and as much as I dislike the word personally, it's an important outlet to consider.
Thank you. Dr. Jinks, you were next in the queue.
Great, thank you very much. And I also want to thank all the speakers. It's certainly a very important topic here. And this is an area where I think we might have had the least progress in terms of the agenda to tackle antimicrobial resistance. But on that, first to answer Dr. Blazer's challenge question, Wellcome Trust chose to preferentially use the terminology drug-resistant infections to try and better engage people outside of the expert community that is stuck with the jargon, so that we could hopefully overcome some of the confusion about what AMR or AR might actually mean. Now, we haven't evaluated the success or the usefulness of focusing on drug-resistant infections, but our initial assessments at least indicate that people do better understand that in their immediate reactions to what's being discussed or talked about. I want to refer to what Dr. Davis is saying in response to, I posted that Wellcome had commissioned a report on the topic of resistance and the need to reframe resistance, how it's referred to. And Dr. Davis rightly points out through work of her colleagues that there essentially is a bias in what that report is saying from Wellcome, because it is focused much more on the human health community. And it in some ways does illustrate the point that she made in her presentation, that there do need to be the tailored strategies for the particular stakeholder groups as we move away from human health into animal health, into agriculture, or the other areas where there are environmental impacts of the resistance itself. So I have a number of questions, but the one I do want to put forward in respect of time is for Dr. Langford, and thinking about the role for communicating with people to get improved participation in clinical trials. And is this something where it's more about focusing on better communication at the point of recruitment, or should we have communications campaigns so that people understand the role of trials and are therefore more prepared to participate in a trial at some point when it may come up? Or is it both? Thank you.
It's both, and that's a great question. I think in general, if you go out into the public and you ask someone, have you ever heard of a clinical trial or participated in one? Probably a lot of people would have no idea what you're talking about. So I do think on one hand, I think people in general don't know a lot about clinical trials and clinical research, or they think clinical trials are only for people who are really, really sick or dying. So I do think we need just general awareness in the public. And there have been some campaigns through like the National Cancer Institute and like CDC, like throughout the years. Some of the research that I have done is really looking at direct to patient invitations. And so historically, especially if you're talking about racial and ethnic populations, a lot of times the narrative has been people are mistrustful, it's Tuskegee, everybody's paranoid. And that's an important piece of the picture. But I think current research has shown that it's probably a lot more to do with logistical issues and lack of awareness and lack of offer, and people expressing interest, but maybe not being able to qualify or being eligible. So I tend to focus more on like logistical issues. So for example, our health system in 2016, we actually turned on the direct to research tab in our Epic system. So patients, if they qualify for a trial, they can be directly invited or get an alert in their patient portal. It doesn't mean they have to do anything, but they can click for themselves to say, yes, I'm interested, or no, I'm interested, and get more information. And clearly that's not going to solve all of our problems, but historically we've had the system where you hope, wish, and pray a physician will tell someone about a trial, which typically doesn't happen for a lot of reasons. One, it's not incentivized. It takes a lot of time to explain a clinical trial. And if you're in a health system like mine, you may have hundreds of trials at any given time. And the doctor's just trying to make sure your blood pressure is okay and your A1C is fine. And they don't really have the time to explain like the 5 clinical trials that you may theoretically be involved with. So I do think we need public education in general, but also more ways for people to at least be aware of the opportunities and to get more information and to seek out potential participation if that's something they're interested in, and kind of moving away from these kind of gatekeeper systems, which we know don't really work and aren't really helping the whole scientific enterprise, especially if we can't get the numbers that we need to actually do the research.
And Dr. Jinks, did you want to comment on Dr. Wheeler's question to you in the chat?
Yeah, so the question relates to whether or not there's updated data in reference to the media coverage since this has been published. And we don't have updated data so far on this. So this is something that we are looking to do, and also wanting to do this with a much more global lens as well, because this is something, I know this forum is related to the U.S., but it is a global problem, and there are need to have improved global engagement on this. And we have much bigger language problems in other parts of the world where antibiotic as a word actually effectively means the same thing as drug or medicine in some communities. So there's a lot of work to be done to understand really how much progress is being made in recent years.
Thank you. Dr. Sheftel, you have a question?
Yes, please. Thank you, everyone on the panel. Again, just a fascinating group of speakers. Katie Capers, this one is for you, and I apologize in advance if it's not an answerable question. So I was interested in the what is the basis or the evidence for the reframing of antimicrobial resistance or stewardship from a societal issue to a personal responsibility in communications? And have you, first of all, make sure I got that right. And then secondly, what other kinds of public health issues have you applied that thinking to? And could you give me an example, since I'm not a communicator? Thank you.
Sure. Happy to start this and welcome input from the other panelists too. I hope that you guys have thought about this and seen it places. We have seen in the research, in the surveys that we've done with Porter Novelli, that people don't think it's their problem. They think that a government agency or researcher will save the day, a new drug will come, and that will heal my infection. I don't have to take action now. We've also heard and have some quotes from folks where they say, that it's too big of a problem. They can't contribute to this. None of their actions are going to help or be beneficial. I think, unfortunately, we saw some of that with COVID. We're too far gone. It's spreading too much. I'm going to go to the grocery store and not wear my mask. What's my vaccine going to do to help? I don't have to. Everyone else is doing it. I think we saw that issue. So people are saying it's not my responsibility. It's a societal issue. And so shifting it more toward some of our testing and our materials that we'll be testing this coming spring and summer are looking at shifting it from a personal problem of you can help to what you can do to help future generations, or what you can do to help improve water safety or animal health. So it's less of your human health, personal health, and your personal actions to protect yourself, and more about what you can do to help others. Well, I probably misstated that a little bit, but what you can do to contribute to the effort long term, instead of maybe seeing an immediate resolution. And then I think I answered your second question with referencing COVID, but I'm curious if other folks have thoughts, especially maybe even from the animal perspective.
Yeah, I'll just add, actually more from the environmental health perspective, that a lot of times we're thinking about this more from an extended parallel process model, the threat efficacy. So if you experience high threat, but feel like you have low efficacy or low control, that can really diminish ability to take action. And that what we really want to do is try to move things into an ability to take action. And so Katie, when you talk about the personal responsibility, I think that's exactly what you're doing, is you're moving it from a low efficacy to a high efficacy kind of scenario.
I'd also mention that, but while that's true about the efficacy and threat, if the threat's high enough, people do take action, and there's good meta-analytic evidence that if the fear of peel actually makes you fearful, you have a response that is typically a response that's in line with the recommendation. So like one of the challenges is it's actually hard to scare people, like because people aren't going to like about a health thing that's really distant. To say like, ooh, that resistance is going to get you in 10 years is really hard to scare people about because it's very far off and they've had those experiences. I would just mention like three things, and when we're talking about this in terms of individual responsibility, something to consider is that people like doctors have a lot of stuff to deal with every day. So like we have to think about a few things, right? Information overload, message fatigue, and fatalism about these things are going to affect sort of, and again, we did see this with COVID-19, right? People were exhausted hearing about all of the things that they were supposed to do or not supposed to do and things like that. And again, we're speaking in broad terms, right? There were also people that weren't exhausted by it, that were every day checking for new information. And so there's variation in how people are going to respond to this. But I think that those three things are important to consider. And I think that, again, confusion I mentioned earlier is something that we often underlook in when we talk about communication. Like we don't acknowledge that we might just be confusing people and that confusion is something that they want some resolution to. And then that if they get too confused, they won't care anymore. And so I think the individual responsibility component for me makes some sense. And I think it makes sense on the animal side and the human side for a piece of this. I think there's a danger in only saying that it's the responsibility of the patient, but it doesn't sound like that's what the CDC is doing with that work. And I see you shaking your head, so that's great. And so obviously that's not the only piece, but I think it does make sense to try to communicate that there's agency that an individual could have, and they could take an action themselves and sort of, you can almost look at it, I think ideally those sorts of message, maybe it's not about individual responsibility, but it's more about conceptually individual empowerment, to the idea like I can do something to make a difference in this side of things. And so I think if we switch that word responsibility with empowerment, maybe it makes more sense, because I think historically individual responsibility indeed gets a bad rap, because what we're trying to do is saying, well, the system's not to blame, it's the individual to blame. And often we've talked about systems approaches. It's more complicated than that again. So I think, to me, it sounds more like it's that empowerment perspective of like, hey, you can do something to make this better if you're worried about this. And that might not work, but that might be something that's useful.
Thank you. Dr. Langford.
Yeah, so actually, I think this is a good piggyback to what Andy was just saying. So I'm always interested in measurement. And I think a challenge with any type of communication is, you can have 10 million people reached or so many clicks or whatever, but then how do you know something has changed, right? And so do we, I don't know, count the fewer number of antimicrobial or, antibiotics prescribed to children? Are we counting converted, parents that we've, convinced that they actually don't need a particular antibiotic? How are we kind of really tracking our success over time with these communication strategies? So I think it's a little bit easier, in a research setting where, you can have someone do a survey and expose them to a message, and maybe their attitudes or intentions change in that moment or that period of time. But when we're dealing with, really public health communication and mass communication, I was just curious, this may be a rhetorical question with no answer, but I'm just curious, what should we be counting over time as success? And secondarily, I have a dog, and I love all of my veterinarians. I think they are literally the best shared decision-making communicators in the world, maybe because the animals can't talk and you're typically paying out of pocket. So maybe you're talking more as an owner. But I was just curious if there's any synergies, not that veterinarians don't already have a lot dealing with the dogs and the cats and the humans, but are there any potential, do you think, collaborations? So sorry, that was two questions.
Yeah.
So measurement, yeah.
Right, two questions. So the first thing for the vets, and the second one, how can we assess our outcomes of our efforts? Comments from the panel?
I'm happy to chime in. I had a big slide of sharing in metrics, so sorry. But that's a great way for us to measure at least immediate impact. We do have long-term metrics embedded in our logic models for each campaign. So get ahead of sepsis, be antibiotics aware. And then, of course, if a campaign for AR were to be justified, needed, and approved, that of course would be embedded as well to the things that you're referencing, Dr. Langford, of are we reducing antibiotics over time, et cetera.
Yeah, and I can comment just a little bit on the veterinarians. I agree that the shared decision-making model is something that I've seen extensively within veterinary practice, both large and small animal practice. As far as really trying to integrate care across the human and animal kind of domains of the household, whether that be a household with a dog or a cat or a farm, right, where you may have some challenges that could impact the health of the actual farmers. I think I've seen potentially a little bit more on the ag side. I know I certainly remember getting trained in communicating human health risks to farmer clients when I was in practice. And so I would say, here's your Mycotil. Do not take this. I know you're going to take lots of the veterinary drugs, and this is one you really shouldn't take, and this is why. And just, preface that every single time I had a sale on that particular drug. But on the small animal side, I think that there are some barriers in terms of really kind of being able to temporally manage the access to services and the long wait times to get in on the human healthcare side. I mean, they're lengthier on the veterinary side than they used to be. It used to be that you could generally get a same day or next day appointment, and I think that that's a much more rare occurrence. But I'm waiting 9 months for one of my healthcare appointments on the human side. And so trying to maybe correct some of the structural challenges there might help to empower communication. Or maybe we need to think about it again from the team model. Does it have to be the veterinarian and the physician who have to link up in order to have coordinated care? And I think the answer to that is probably not. Maybe we need to think about other allied professionals as really being our tools to manage communication strategies and, if needed, harmonized treatment approaches across the veterinary and the human healthcare sides.
Yeah, I think convergence on the animal ag side is less likely than on the companion animal side if there was going to be sort of an overlap, just because veterinarian, again, I'm not a veterinarian. And so if there's a veterinarian on the call who wants to correct me, but my understanding is that there's a lot less interface between, livestock vets and sort of human health doctors generally. And so and even in sort of accidental overlap and that sort of thing. And I think that Aisha, your comment about outcomes, I think it goes back to, for me, it really goes back almost completely into the behavior outcome thing, is that ultimately with a lot of these topics that we're talking about, we want people to change their behavior. Sometimes we just want them to be informed, and that's fine. That's a fine outcome. If we want them to learn something, that's okay. I'm not saying that I said earlier that I was really against the deficit model. It's not that we don't want people to learn stuff. Sometimes they have to learn something before they can change their behavior, right? I don't have kids, but I was a kid. And one of the things I was always really good at with my parents was telling them how great that experience was for somebody else. And then about a week later, asking them if I could do it. Because I wanted them to be thinking about how great it was that kid did. And then the same thing applies. That same concept applies, right? We're sort of priming this idea and trying to engage action later. That's a common communication approach. That's been used for decades successfully. And so in the case of a lot of behaviors here, I think the key is identifying those behaviors, which is actually not a communication problem. Initially, it's not that communication is not relevant to that, but if we're going to try to get people to engage and change, that's something that communication can be good at helping doing. But we have to have that sort of recommended behavior to change. And that goes across, again, animal, environmental, and human health. Like, they're going to be different behaviors, but having an index of behaviors for each of those areas from a One Health perspective would really be really beneficial to improving communication in the future. And I think, to Aisha's point, would give us a set of outcomes that we could then have as targets and that we could measure over time in a variety of different contexts, both locally and more at a sort of a national level and internationally for that matter.
Thank you. Dr. Fernandez.
Yeah, I had just a very small comment. I've also encountered this notion about antibiotic resistance. The person becomes resistant. I've heard it a couple of times. And I find that these are the people who are aware of patients who've been treated, them or their relatives have been treated with anti-cancer drugs and how their tumor became resistant. And so they're kind of related to that, I think. So if we can kind of differentiate it from cancer resistance versus antibiotic resistance, antimicrobial resistance, that would be good. If out of the 2 or 3 people I spoke with, they had the same concept, then it must be more general than you think.
Comments?
I'll say that.
Yeah, go ahead, Andy.
Oh no, I was just going to say, I think I appreciate that because I think it gets to some of these very specific language decisions that will be important considering sort of moving forward, which is that, the terminology and making those decisions about what are the ways to sort of unify that language and standardize that language so that there's a way to talk about this both across environmental health and animal content, environmental, human health, all of them are health, in animal contexts are important. And that thinking about the ways that it has an overlap with some of these other potential disease areas is important to both differentiate, but then also potentially take advantage of maybe if there are pathways of understanding in one of those other areas, is there a way to sort of just convert that pathway as it relates to AMR broadly considered?
Dr. Dixon.
Yes, thank you. I'm just following on Tim Jenks' comment about is the goal to raise awareness about the importance of clinical trials and people participating in them, or is it more about the recruitment for an individual trial? And I think he was insinuating it's both. And I would agree and said that key is what's the context of the trial. And so my experience is in the last dozen trials I have been personally involved with for leading at NIH, since my group focuses on the so-called escape pathogens, this is primarily the healthcare setting. And so there is no encounter with the patient until they are hospitalized or reporting to an emergency department seeking care for an urgent infection. And so you can't recruit to that very well, but you can educate about the willingness to participate should they ever be in a situation. Yet I would say that the reason I use communication 3 times, the most important thing here, communication, communication, and communication, is it's also important within the healthcare team. And so the sites that were most successful in hospital-based infection trials were those where there was an effective communicator as the investigator who could speak frequently and passionately with his healthcare team or her healthcare team, the laboratory, isolating the organisms, the attending staff treating the infections, and the patients themselves in order to interest, recruit, and retain subjects to answer scientific questions.
Thank you, Dr. Dixon. It does seem that the siloed nature of healthcare makes it difficult for, as Dr. Langford said, why don't treating physicians mention the options for clinical trials? But it seems that we're all in there with a message we have in mind, and that's it. So, Dr. Ashley.
Hi, I want to echo the comments of everyone about what great presentations we've had today. But and this is a little bit for this group because I feel like my comment is going to apply somewhat to what was discussed for the public. But something that stands out to me a lot as I look at the course of the day is I feel like we're leaving a big middle constituency out of our communication plans. And that's getting from the hospital health system and subject matter experts to the providers who are then going to be the ones facing the patients. And I feel like that's where so much of the confusion comes in. And I think some of it was brought up in the agriculture realm, but I would really challenge us to think about that as well, and how the front line, the doctors, the nurses, the pharmacists, the physical therapists who are crafting a lot of messages towards our patients. So that was a lot of inconsistency around, previously it was raised about, the public health perception around ivermectin. There were also a lot of health providers talking about that, and what are we not leveraging to speak to those groups? Because I feel like in the past pandemic, that was one of our greatest challenges, is the subject matter experts weren't getting information quickly enough. But how do we help communicate that more broadly to the general public of the healthcare provider?
I love that. I'll respond just initially and say that I really appreciate that point, because working on both sides, working on human health projects and working on animal health projects, I think animal health folks are always very systems focused, always. Like, it's because they work in systems. Like, they constantly are working in systems and have that approach, and everything they learn seems to be based in a system, whether it's about the animal or whether it's about the industry, and et cetera. And I think on the human health side, there's much more compartmentalization and sort of more deferential expertise than there is on the animal health side, where there's a lot of mutual respect. We're like, well, this person does this person, like, there are more defined roles, and again, that's just my experience. I'm not saying that that's the case. So I think it's a really important observation. I don't have a good solution, unfortunately, to offer you, Libby, but I will say that, like, it's a great thing to bring up, and hopefully some of the other presenters or other folks that are on the call have some ideas there.
Yeah, Dr. King, I completely agree. And we actually were measuring some of this, right? The push down to your frontline workers within the veterinary and animal care workforce study that we did, the COVET study. And we're still digging in on the qualitative side to understand what those channels of communication were and what the frequency of communication was and how that then related to what the perceived readiness, willingness, and ability of the veterinary and animal care workforce was to respond to the pandemic, because they were essential workers. And this was during, period of time when there were a lot of lockdowns as well. And I think that what this kind of points to is maybe in the hot wash of the pandemic turning endemic, that we can think about the motivation to really establish very clear lines of communication with frontline workers and then operationalize it on a day-to-day basis with AMR as just a perfect way to do so, right? I think there are additional opportunities that we have, but identifying what all of these different strategies are to reach the different groups may be critically important. And I can't speak to the human healthcare side. I've only looked at it, again, primarily within small animal practice and a little bit within some of the other animal care workforce professionals.
If I can just add on to that, when we're creating our communication strategies, of course, at CDC, this isn't unique to CDC, but anywhere, we always are listing our primary audience, GenPub. We almost always have a secondary audience, and that's going to include the pharmacist, the vet tech, whoever is going to interact with the patient next, because we're going to not only make materials for that primary audience, messaging for that primary audience, but also the that secondary as well, because they're going to be the ones that have influence, can help answer questions, change perceptions, et cetera, with that primary. In Be Antibiotics Aware, we are focusing a lot on improving antibiotic use, and they have a ton of materials for those secondaries. However, that's just focusing on the antibiotics solution. So we don't have great communication and materials for those sub-audiences or secondary audiences specific to AR. So you can increase vaccinations and that will fight AR. You can improve your infection control, your hand hygiene, all these other tactics that we have in our pocket, so that they're not relying on that drug manufacturer or relying on the researcher or relying on the antibiotic. They're actually relying on these really simple, practical things they have in their back pocket. But tying them together, given all of today's conversation, I think is the confusing part, and one that we all have to work on together for sure.
Thank you. Dr. Davis, did you want to mention?
Yeah, I was just noting, I was really impressed with how during the pandemic, how closely collaborative in their communication the CDC's One Health office was with the American Veterinary Medical Association. And so I would tend to see the exact same messaging or really complementary messaging coming out temporally consistent with each other from both of those avenues. And so as a veterinarian, I felt like it was a reinforcement of the message rather than, having all of these different messages that then I had to synthesize. I felt like it was already synthesized for me. And that may be important as we try to reach our frontline workers.
Thank you. Dr. Langford, I have a question for you. I really appreciated you suggesting some solutions or approaches to this problem. You mentioned Medline Plus and you mentioned shared decision making. But what kind of uptake have these things had yet? Because the public, they need to know they exist to be able to even find them. And my sense is that the public is not has not taken advantage like they could or should of the resources like that.
Right. So I'll start with the shared decision making. So that's more of a process that ideally, clinicians, and that could be, nurses, physicians, dentists, et cetera. And I think implementation of shared decision making overall has not had huge uptake in healthcare systems. I think in part because it's kind of like health education in general. It takes time. And you can't really reimburse for shared decision making outside of like lung cancer screening and a few cardiovascular things. So I think that's a challenge. I think people agree that it's good to talk to patients and involve them, but everything's about time, especially in situations where you are in an RVU setting where you have to like document and bill every single thing of what you do. With regard to Medline Plus, I know I'm actually part of 2 health systems. It's a long story. I know that Medline Plus is integrated in several patient portals. So for example, it's not in all patient portals, but in the 2 large health systems I'm in, and I believe my parents have it also in there with Kaiser Permanente, which is a big system in the West Coast and throughout the country. So like say you get a medication or procedure, you can have information, I guess, presented in the patient portal that you can click on. And a lot of times that actually is linked directly to Medline Plus. I don't know how many health systems have that integrated, but I know that Medline Plus is working with many healthcare systems to do that. I talk to my family and friends a lot. That's the place I go to. Just because I feel like it's very user-friendly, it's digestible. I don't have any stocks or bonds in Medline Plus or the NIH National Library, but I do think the information is very helpful. So I think it's just kind of maybe it's going to happen organically like this. But I do know that the National Library of Medicine did have some partnerships and grants for public health libraries. I think it's still continuing, but I worked with the group in the Brooklyn Library System where they were working with consumer health librarians to educate the public about how to find reliable sources of information. And some of those teaching modules did use Medline Plus. Again, I don't know how many public libraries across the country, get those types of grants, but I know there are efforts, but like anything in research and health care, it could be better.
Okay, thank you. Yeah, just to follow up on your comments about the shared decision making, I think you're right that it has to do with time. It takes a long time, but there's also some research to show that providers believe that the patients expect and want an antibiotic, and sometimes it's another time thing. That rather than taking the time to discuss the pros and cons of various approaches, it's just simply faster, and they also don't want to alienate their patients. It's just faster to write a prescription. I don't have a sense of how common that is anymore, and I don't know if anybody else on the panel or the council has any sense of that, but it is a concern. Now we have about 4 minutes left. Julie, one more question, and then I want to ask the panelists one final question.
I'll let you ask that final question.
No, you go right ahead.
I was just going to respond to the point you put out there about the patient demand for unnecessary antibiotics. So that is an area I've done a lot of work in, and it remains a concern for clinicians on the front lines. There's really interesting evidence around the gap between what patients actually want and what clinicians think they want, and work that has started in pediatrics but is now moving to the adult side of training clinicians in simple, low time-intensive techniques to communicate with patients about antibiotics to reduce demand and leave everybody feeling satisfied. So there are resources out there for that, and I think it's an area people are continuing to work on. So thanks.
Wonderful. Well, great. Thank you. Just to make sure that I'm not hogging the last 4 minutes here, does anybody else have a final question? Otherwise, I would like to ask the panelists if you would please think for a minute about specific recommendations you might have for communication with the public for PACCARB.
I would say integration from a One Health perspective in terms of communication strategies is probably my top priority and my top message for you today. And I really appreciate the time that you're taking to listen to us and to engage in these conversations. And a huge shout out to the other panelists who are absolutely amazing. I'm in great company.
I'm really interested broadly in this idea of like what the clinicians, and I'm using that broadly, who they deem as like reputable sources or like where their go-to places are. I think we have a lot of information about consumers, but doctors, nurses, veterinarians, they're humans too, and they have different views as well. And so I would be curious if there's a survey or some kind of parallel inquiry around over time, especially during the pandemic, but in general, who are, their trusted sources of information, whether it be like the professional organizations, AMA, or the nursing societies or CDC, but where are they going to first and why? And where they feel like they should be getting those updates for like huddles and things.
I'm going to build off of that, Dr. Langford, and say that we do have some of that data. We probably need even stronger data across all of the different audiences, but I would challenge PACCARB to invest in more partnerships and relationships, because solving this problem is not going to be a one size fits all solution. We cannot just invest in the big and shiny campaigns. We have to be able to go to community events and invest in partnerships and relationships at the local level where we can have impact. We need the big and shiny, but we also have to have the small stuff too for the entire spectrum.
Oh, fantastic. It's a terrific panel. Did somebody, Andy, sorry.
That's okay. They're not that exciting. I just figured I would chime in since I was, I figured I wanted to get that meter to full. Anyway, I was just going to say my suggestion would be on the animal agriculture side is to provide more behavioral recommendations explicitly, because I think that, again, working in animal health and human health, I think everybody that's a stakeholder on the animal health side is really excited about figuring out how to be better and contribute to AMR efforts and to become antimicrobial stewards, if we're going to use that term. But I think that there's a lot of loss about what to do. And so we were talking earlier about individual responsibility. I think, again, reframing that a little bit more as individual empowerment for those different stakeholder groups would be a really useful way to get more buy-in. And I think that there's a lot of interest as well. And then we can focus on the integration, and we can focus on the big and shiny and the grassroots efforts on the animal agriculture side in time. And I think that's a great perspective. And I think one thing that we haven't talked about too is to consider the integration of environmental, not sort of as an independent thing, but as something that's included in animal and human conversations, because there is overlap there, and there's maybe nothing in the very direct middle, but those spaces that Megan was talking about, I think are really important to talk about. And we do overlook them, even if we have private conversations and write grants about them, we overlook them in the actual practice. And so I would encourage sort of promoting those intersections as areas of focus moving forward.
Well, thank you so much to all four of our panelists. They were terrific. And I'm going to turn it over now to Dr. Musmar.
Thank you, Dr. Larson, and thank you to all of our panelists. And again, a fantastic conversation. We're keeping track of everything, and especially the chat that we have that isn't available over the stream, but we have. So if anyone has any comments or questions, we're available to provide the links that were shared. We are going to continue on to the public comment portion of this meeting. Any comments that were sent to the CARB at HHS.gov mailbox were already shared with the council members, as indicated. And we actually do have quite a lineup for this afternoon. Just a reminder, given the number of people that have signed up and with us right now, please do try to limit your comments to 2 minutes, or else you'll get a nice little chat box ping letting you know that you're over time. The first comment comes from Thomas Heyman from the Sepsis Alliance. Are you with us, Thomas?
I am. Thank you very much. And I want to thank PACCARB for organizing these 2 days, focusing on the critical issue of AMR, and for the opportunity to provide public comment. My name is Tom Heyman. I'm the president and CEO of Sepsis Alliance. Sepsis Alliance advocates on behalf of the 1.7 million individuals diagnosed with sepsis each year in the U.S. and the families and loved ones of the 350,000 who perish each year, someone every 90 seconds. We also provide support for the millions of survivors who suffer with the lasting after effects like amputations and PTSD. We also know that medically underserved communities are less likely to be aware of the risks of infection, AMR, and sepsis, and underserved communities are much more likely to suffer the impact from AMR and sepsis. As many of you know, sepsis is the body's overwhelming response to an infection, be it bacterial, viral, like COVID, parasitic, or fungal. Life-saving treatment requires effective antimicrobials administered in a timely manner. Antimicrobial resistance directly threatens our ability to fight sepsis. With a diminishing supply of effective antibiotics and other antimicrobials, more infections progress into sepsis, and sepsis becomes increasingly difficult to treat. More people will die, and more will suffer harmful after effects. It's critical for us to understand and improve our understanding of AMR and its place in society as a major public health crisis. We need to focus on education and communication. A recent Sepsis Alliance survey found that among adults in 5 countries, including the US, only 52% of adults are even aware of the term antimicrobial resistance. We need to invest in public education if we're going to bring them along on this journey. And among healthcare professionals, there are also major educational opportunities. Another recent survey conducted by Sepsis Alliance found that while 90% of ID physicians and pharmacists can consider AMR to be a major problem, only about a third are familiar with current legislation and policy solutions. We need to do a better job at bringing our healthcare professionals into our solution team. The good news is that public awareness, effective communication, and education efforts can make a difference. When Sepsis Alliance was founded back in 2007, familiarity with the term sepsis was at only 19%, and Microsoft did not have it in its lexicon. Today, fully 66% of the nation is at least familiar with sepsis. In support of deepening our understanding of AMR and its impacts, Sepsis Alliance is advancing the creation of a national sepsis data trust. Inspired by the National Cancer Registries, which dramatically advanced our understanding of cancer, the National Sepsis Data Trust will harmonize existing data, help us understand the heterogeneity of infections and the body's immune response to these pathogens. For more information on this work, you can visit us at sepsisregistry.org. Additionally, in support of further educating healthcare leaders about AMR, Sepsis Alliance will be hosting a 2-day AMR conference on April 26 and 27, free of charge, including a session from the CDC on its antimicrobial stewardship core measurement program. Information on that event can be found at amrconference.org. Sepsis Alliance looks forward to continuing to work with PACCARB and other partners on improving our shared understanding of AMR and building strategic solutions. Thank you very much for your time and your attention to this critical public health issue.
Thank you, Tom, as always, for joining us on behalf of Sepsis Alliance. Next, I'd like to call on Janine Thomas with MRSA Survivors Network. Janine, are you with us?
Yes, I am. I'm having trouble with my photo. There I go. There I am. According to the World Health Organization, antimicrobial resistance, antibiotic resistance is a major global health concern. We have known for many years, yet little has been addressed to change the trajectory. We know that prevention saves lives, but yet we have not done everything we could to stop MRSA and staph infections in healthcare facilities for decades. We need to do more, and we can do that. I am very thankful for all the healthcare workers and their families who made a huge sacrifice during the COVID-19 pandemic and continue to sacrifice their health and well-being for MRSA patients and for COVID patients. Over the years, many healthcare workers contracted MRSA and other HAIs while on the job. Your sacrifice is enormous. And I am personally here today because of the night nurses who saved me from undiagnosed MRSA sepsis. With healthcare-acquired MRSA infection rates having increased up to 25% since the beginning of COVID pandemic, we know that we must be committed and fight hard to prevent these infections. Many healthcare facilities stopped screening patients for MRSA, and this was a disaster for patients on top of COVID infections. Over 250 peer-reviewed published studies have proven that screening high-risk patients, along with strict hand hygiene, contact precautions, thorough decontamination of surfaces, decolonization and isolation of MRSA-positive patients, and a good antibiotic storage program can make a huge difference and save lives. Northern European countries such as the Netherlands have screened patients for MRSA and have been successful in reducing MRSA infections and deaths. The U.S. Department of Veterans Affairs sharply reduced MRSA infections by 80% within 7 years in all of their 150 facilities by universally screening all patients. What patients want is not more non-inferior products and therapies to treat pathogens and infections, but superior products. We hope companies will continue to take the time to develop superior products that will have less adverse side effects. The key to reducing MRSA and HII infections is a preventative approach, and we commend the companies and researchers who are developing these products and also healthcare facilities who are committed to reducing infections, death, and needless pain and suffering. Thank you.
Thank you so much, Janine, for joining us on behalf of MRSA Survivors Network. Next, we have Kevin Kavanaugh from Health Watch USA. Welcome, Kevin.
Well, thank you very much. As the committee is aware, the CDC has reported an increase in antibiotic-resistant infections during the COVID-19 pandemic, including Candida auris, Group A and B Streptococcus, Salmonella, ESBL-resistant bacteria, ALES. There is even more of a concerning increase in resistance in hospital onset infections. And these include Candida auris, CRE, ESBL-resistant bacteria ALES, vancomycin-resistant Enterococcus, drug-resistant Pseudomonas, and MRSA. There is concerning evidence that this rise in resistance will be compounded by a lasting immune dysfunction produced by COVID-19. The recent surges in hospitalizations from the respiratory syncytial virus in the United States exemplifies this problem. Not widely reported by the lay press, the United States, Germany, and Sweden had large RSV surges not only this year, but also last year, shedding significant doubt on the immune debt hypothesis. Sweden also had very little masking and few closures during the pandemic. Immune dysfunction from COVID-19 is also supported by clinical studies and abundant laboratory evidence. A non-peer-reviewed study observed almost 100% increase in risk of RSV infections in COVID-19 patients compared to controls. 9.7% of children who did not develop an RSV infection had a documented COVID-19 infection. This contrasts to 19.2% of children who developed an RSV infection and had a documented COVID-19 infection. Another study found a 34% increase in risk of streptococcal tonsillitis in COVID-19 patients compared to controls. The best policy is to prevent patient exposure to drug-resistant pathogens. Screening and surveillance must become a leading strategy upon which others are added. In the case of hospital onset MRSA infections, private sector healthcare in the United States experienced a 17% increase above their 210 to 211 baseline, as the Veterans Health Administration, with a uniform strategy of surveillance and contact precautions, experienced and maintained over an 80% decrease. We need to remember that no matter how high risk a patient is, one will only become infected to a drug-resistant pathogen if one is exposed to it. Thank you.
Thank you, Kevin. Next, we have Myra Ryder from Farm Worker Justice. Myra, are you with us?
Yes, I am here. Thank you. Good afternoon. My name is Myra Ryder, Project Director for Occupational Safety and Health with Farm Worker Justice. I would like to thank the Council for the opportunity to speak today. Since 2016, the U.S. Environmental Protection Agency has made several decisions authorizing the use of streptomycin to combat citrus greening in Florida. The 2021 registration decision allows this antibiotic to be used on citrus until 2028, potentially resulting in more than 650,000 pounds being sprayed on citrus trees in Florida and California. Unlike with medical prescription of antibiotics, there has been little communication to affected workers and communities regarding the risks they are exposed to. They also have little power to control these risks. These applications expose farm workers and communities near citrus fields to unacceptable risks, including allergic reactions and the development of antibiotic-resistant bacteria. Farm workers are at risk of exposure when they mix, load, and apply antibiotics, as well as when they enter sprayed fields or when they are exposed to pesticide drift. EPA itself has acknowledged the risk of bacterial resistance posed by this practice, but the agency believes that the use of personal protective equipment will lessen the risk of farm worker exposure. However, this ignores the fact that farm workers are not always provided adequate protective equipment by their employers and frequently lack training in its proper use. Furthermore, re-entry intervals that are intended to protect workers are also frequently ignored. The risks of these exposures have not been communicated properly to farm workers or to fence line communities. As a matter of public health and environmental justice for farm worker communities, these uses should be eliminated, and exposed communities must be informed of their possible exposures so they can receive appropriate medical care if they experience health effects. Thank you again for considering these comments.
Mayra, thank you for joining us today on behalf of Farm Worker Justice. Lastly, we have Ted Schroeder with Antimicrobials Working Group. Ted, the floor is yours.
Thank you. I appreciate the opportunity to speak today. I served as the CEO of Nebriva Therapeutics from July 2018 until just last week and continue to serve on the board of directors. I'm also speaking today in my capacity as immediate past chairman of the Antimicrobials Working Group, an industry-led coalition comprised of emergency antimicrobials and diagnostics companies. I'd like to use my time today to underscore the dire state of the antimicrobials industry by using the story of Nebriva Therapeutics. Nebriva was founded in 2005 with a mission to develop novel antibiotics to treat infectious diseases, particularly those caused by multi-drug resistant organisms. Despite the many challenges of antimicrobial development, we succeeded, bringing the novel antibiotics and led it to the market in 2019 with a QIDP designation. Despite our successes on the scientific, technical, and regulatory fronts, the dysfunction of the commercial market would prove to be our undoing. As things currently stand, the market is unable to sustain small companies with newly FDA-approved antibiotics, despite the clear life-saving potential of these drugs. On January 6, 2023, we publicly announced a strategic plan to preserve cash as we engage in an orderly wind down of the company's operations. This was not an easy decision to make. We are acutely aware of the impact of this decision on our employees, our partners across the globe, continued investment in the space, and importantly, the patients who rely on our products. In September 2022, PACCARB issued a task letter to HHS Secretary Becerra with recommendations to improve the antimicrobial commercial ecosystem. On behalf of many of the struggling small biotech companies in the space today, I urge PACCARB to revisit this letter and reiterate its points to HHS. Moreover, I'd encourage the Council to consider both long-term solutions and near-term strategies to preserve stewardship, protect IP, and ensure continued patient access to innovative and safe antimicrobials. Today, the industry is at a critical inflection point. We urge the Council to ask HHS to take immediate near-term actions that will preserve the essential capability to develop the medicines of the future while continuing to support safe drug development, appropriate use, and product access. Thank you for your time.
Ted, thank you for joining us on behalf of Antimicrobials Working Group. That concludes our public comment portion of the day. Folks, if you need to send a comment to the Council, please email us at CARB at HHS.gov, and we'll be sure to share that with all of the Council members. Next, I would like to transition our final thoughts over to Michael Apley, where we'll hopefully have just a final discussion before we wrap up.
Thank you, Dr. Musmar. I would like to invite the Council to have time for some comments, some closing comments for today in the round robin format we've used in the past. And I'd welcome you to raise your hand and we will call on you and ask you to participate. There we are. Dr. Blazer, we'll start with you and let everyone come in line.
Thank you, Dr. Apley. It's been a full day. We have really had a lot of information from the very beginning to the end. And I'm just going to mention a couple of points that I came out from understanding. And it consolidates my view that the problem of antimicrobial resistance is kind of a tip of the iceberg. It reflects so many different kinds of problems together. And I'll just list a couple of of issues that came up in one form or another in the day. One is the lack of trust in authority. We learned about the value of the extension veterinarians, but wonder if there's a missing echelon in public health akin to them. We learned that, not surprisingly, that students are concerned whether things are on the test or not. That is what kind of motivated their learning, which I think is, unfortunately, it's prevalent and doesn't help people see the big picture. Again, as was discussed, there's an insufficient background knowledge in the United States about science, and that kind of thwarts our major issues. And as Dr. King told us, that rather than misinformation being the majority problem, he indicates that it's a small problem, but confusion works in favor of misinformation. The two are synergistic. And just now I learned about the spraying of plants and farm workers with antibiotics, revealing yet another problem. So a whole mixture of different issues. Thank you.
Thank you. Dr. Newland.
Thanks, Mike. I'm glad we're doing this again. It was a lot of fun, obviously, when we did it around the table, and I think it was in September. I look forward to March. I'd like to say, man, we started like with a bang, right? I mean, I think, our future doc, Kinnaman, and her, I think, statements around her experience, as well as what her colleagues think, is a challenge for all of us. And I would say, I think of this in terms of this pandemic response as I'm mulling over a talk on COVID-19 impact in schools for a presentation regarding Black History Month in the next couple of days. And I think about Dr. Chan and his response to our federal responses and our need for, how we could potentially help each other in developing responses that are on par. Maybe, like, can they keep up the pace? And can they do that? And I think about that issue around pace and speed that was needed for the COVID-19 pandemic that in the end kind of sunk us at times, to the notion of antimicrobial resistance. And as Marty just mentioned, that, and others have mentioned, that education doesn't seem to be there for everybody. And I don't know if I'm that surprised by that, but it is clear to all of us that our educational efforts will need to be continued, and likely need to be done in ways that we have not done before. And while Marty is not upset, sorry, Marty, I wouldn't say that, but Marty has struggled with the notion that students are there to take the tests, I'd say the system we have created has made them have to be that way. Because if they're going to get the top-notch residency or their top-notch fellowship, they're actually required to get the most objective factor, which happens to be a test score. And while we try to do this all-encompassing ways, that's hard. But how do we change that? Because I agree with you, Marty, 1,000% that, boy, I wish I could have focused more on the learning and what was important, because that's what matters more as we go and talk to the people that are impacted by these antimicrobial resistant infections or things that really scare them. And lastly, I just say we're all a part of the public, and how do we be more a part of it so that we can actually educate them so that they understand what we understand? Thanks again, and I appreciate the round robin.
Thank you. Dr. Simzik, I can't imagine anyone on the council who today would be more of a day. It's a great day.
Yes, no, I really do want to thank all the panelists and for PACCARB for giving this topic such time and attention. I think the top level takeaway, which wasn't a surprise to me, but was emphasized today, was the unbelievable complexity and interconnectedness of all of this, that you can't focus on one part and expect it to fix the problem. And even focusing on one part can have downstream effects in another part that you don't expect. So I think just reminding us of the complexity and interconnectedness always is important. But in thinking about our, report and thinking about pandemic preparedness, and one thing that just stood out to me that I wasn't necessarily expecting, but I think is critical, that we heard in the September meeting, was the importance of shoring all this up in non-crisis or non-pandemic times. And that, as we talked about in our last meeting, a lot of that's about investment, about, thinking about these kinds of building these relationships, supporting these kinds of structural drivers of these problems in non-crisis time is just as important for the communication dynamics as it is for the diagnostics, the therapeutics, all of what we talked about. So I know that's a message we're going to include from our first meeting, but I think we should also connect that in our recommendations about communication in our report from this session. Thanks.
Thank you. Dr. Ginocchio.
Yeah, it was absolutely great session. Two main thoughts of mine were first, again, started with Dr. Kinnaman, our future doctor. And what I have to say is that she's really lucky to be at an institution where offers a program that teaches antimicrobial resistance, microbiology, and part of immunology. And I really question how many medical schools across the country actually do that. I know in our transition on medical school, as the curriculums got worse and worse and worse with more things to be included, this became a 1-hour lecture, in the course of, how many years of training. So I think she makes a really good point there. And she was honest. She said, well, if I didn't have my own MRSA, maybe I would have never even been interested in AMR. So it's terrible that a life experience had to draw her to that. But how do we encourage our medical schools? How do we get our students? Those of us in ID this year, our residency match was disgraceful. We can't even fill our fellowship programs with people that are interested in going into adult infectious diseases. So that's really a sad kind of statement, considering that this is so critical. So we've talked a lot in the other meetings about how we need to integrate AMR training and teaching throughout all of the healthcare professionals, and not only in medical school, but through continuing education for our outreach community physicians too. And I think we really have to go back and emphasize that. And the other point I'd just like to make, I really liked everything about communication across different groups, communication. I think people are really doing great things, but at the same time, they really highlight some of the difficulties that we have in keeping open communication, whether it be to the public, whether it even be within the healthcare profession. So that, again, is something that really needs to be addressed in the new recommendations.
Thank you. Mr. Nahum.
Well, I gotta say, 3 years ago, when I was first sworn in, I remember going upstairs for a similar round robin, just a discussion afterwards. And I remember mentioning communication, the importance of communication. So I can't thank PACCARB enough for putting it on the agenda. It's just, what a wonderful day. My comments I want to make is that although I heard briefly this mentioned, but not really enough, and there's no silver bullet that I know of to fix the communication issue that we currently have. But part of the fix is what I do every day as a patient safety advocate, is that back in 2018, I was part of a study where we engaged high-performing, mid-performing, and low-performing hospitals across the country. And ironically enough, we found out that the high-performing hospitals that engage patients as advisors have better communications than other hospitals. And I found that amazing. The very same people that you serve are the ones that actually are telling you how to communicate with them. How ironic is that? So I encourage to maybe pursue that avenue a little bit more, because again, it's not the answer to all, but it's certainly a big important factor in the communication level. And the CDC does a wonderful job. They engage me a lot in their communication strategy, and others like me. But I just think that not enough is done in that area, and I think we should pursue that a little bit more. But thank you for today. It was wonderful.
Thank you. Dr. Carricker.
Well, just a couple of points that struck me today. I really enjoyed the conversation, and the more of these discussions and meetings we have, the more I'm struck that the challenges in the veterinary arena and the challenges in the medical arena are very similar, in that we've got a lot to learn from each other and a lot of opportunity for synergy moving forward. I thought the points about education were very important. That's part of my primary task. And it strikes me that a generation ago, you attended medical school or veterinary school and you left with treatment or regimen information that you carried with you out into the community and applied. And now everyone has access to that. That's not a unique piece of information or skill set. And what we've got to do is train veterinarians and medical professionals in general to be able to work through the reasoning about which of those sources is correct and how to sort through the information that people receive, that this clarification of communication and figuring out what constitutes evidence versus what constitutes chatter is a very important part of education that we've got to find room for, and we've got to find ways to emphasize. And then I think part of that is, if you do that continuously, you address some of the other issues of building trust, for example. I was sort of struck by what Andy King said in terms of, your response or your messaging in a crisis doesn't go very well if you don't have that planned already, if that trust doesn't exist, if that isn't practiced routinely. And so maybe if we ramp up that process outside of times of crisis, then potentially we are more trusted resources when those situations arise. So just want to thank everyone for the dialogue and the discussion. I think a lot's gained by all of us interacting and sitting down at the same table.
Thank you, Locke. Dr. Black.
Hey, I want to thank everybody also for a fantastic day. This has been fascinating and motivating as ever. I wanted to just speak to Katie Capers from CDC, kind of set out a challenge about addressing partnerships at the local level. And we're really interested in engaging underserved communities as it relates to AMR, both on the patient level and also provider level. Providers like at FQHCs, for example. And I'm already planning to use kind of material developed by HRQ for, that Sarah Cosgrove worked on in outpatient settings, but I'm really interested in kind of material that's sensitive to engaging, communities that are having a lack of trust in vaccines, being felt to be prioritized because the vaccine is still, experimental, quote unquote, getting individuals interested in participating in clinical trials and kind of working with both patients and providers, again, in a time when we're not in crisis. So I'm looking forward to tomorrow, where I hope these topics will kind of bridge from communication into underserved communities. So thanks a lot.
Thank you. Dr. Craig.
Thanks. And I think the thing that I would note for everybody is, I think the major thing that we heard today is that it's less about the communications and it's more about the audience and what the audience hears and what the audience understands. And the behavior change is fundamentally very difficult. And I think the other thing that is very humbling for all of us is that the topic that we deal with and the topic that we have to address here affects everyone. And I don't mean that it affects everyone. It literally does affect everyone. So when we think of our audiences and when we think of our behaviors and we think of all the different things that potentially could change in the partnerships, it is daunting. And there's a lot of work to be done here. And there's only the possibility of getting it done by working together and collaborating and leveraging one another and using that. And so I think that's the thing that, we go back to, and I think a lot of times CDC is looked on as a source of information and, how can we better communicate and improve our communications? And I will 100% be the first to say we absolutely need to do a better job with those things. But I also need to say, and I think it's important to note, that we cannot do it by ourselves and that we have to do these things in concert and collaboration with other partners, with, all of the One Health spectrum of partners, with patients, with families, with healthcare providers, and the gambit of healthcare providers. It's not just one type of healthcare provider that we're talking about that's affected here. It's a whole variety, and they all have different preferences and different demands and challenges. And those are some daunting things that we have to address. But I think this is a good discussion that I think puts the complexity on the table and challenges us to try to come up with solutions that are not just simple, because a lot of these things do require a lot of thought. And I will also just say thought and continual ongoing effort and evaluation and improving on what we did yesterday so that we can do it better tomorrow.
Thank you. Dr. Cray?
Yes, thank you very much. I agree that communication and audience is a major focus area for PACCARB and something that we need to continually bring to the forefront. Armando is right. We did talk about communication several meetings ago, and as we can see that we're bringing much of the same subjects back to the forefront to discuss again. I am, however, passionate about starting with an audience that is younger. I'm continually amazed that going into elementary schools and high schools and teaching young people about antimicrobials, about bacteria, washing hands, hygiene. We saw this during COVID with the wearing of masks and proper hygiene. And I can't tell you the number of faculty who come and tell me that their children question their doctors, those that are old enough or precocious enough, about the need to take a pill. Like, do they need that? Do they have to have that? Is that going to help them? And I really believe that's one area that we have not focused on and that we continually need to focus on and bring to bear. They will be our advocates. They will be the change force that we need. Many of us are long in the tooth. Teaching new things is sometimes a bit difficult. And it's important for us to remember that we have advocates in our own family. Thank you.
Thank you, Dr. Cray. Dr. Fate.
I'm just going to focus in on the one of the things that it hasn't really come up yet, and that is there was some discussion about development of guidelines and clinical guidelines and guidance and so on. And if we expect that in the face of the pandemic, which is a pandemic, which is what this is, our task is about, and we expect that during that pandemic, additional or new or revised guidance and guidelines will be disseminated, regardless of what the avenue is or how they're communicated. At least on the veterinary side, we actually have to, and maybe it goes back to what you're saying, Paula, about education, is training our clinicians or making them understand that actual value of guidelines, that their personal expertise is not the only evidence that is available to help them make decisions, and that well done guidelines actually make their lives easier rather than harder. And so helping, whether it's students, residents, whatever, how to use them, how to share them, how with their clients, with their patients, and so on, how to create them, and how they are created, and to champion them as opposed to denigrating them. So there are corporate practices in the United States right now in veterinary medicine where there are they're not even guidelines. They're the formula of how you practice, and others. And there are people in the profession who say that's not a good idea. We shouldn't practice in a formulaic way. And so anything that tells me how I should practice is not useful, is not to be trusted, and so on. And so I think there's some fundamental education that needs to happen. And on the veterinary side, we don't have any guidelines. Back to what Dr. King was saying about, we don't have anything in the non-crisis times. We don't have those now for many things. The ISCAID guidelines are great. There are a lot of veterinarians that have never heard of them and have no idea how useful they can be. So I think there's awareness of that sort of gap in understanding would be helpful to this discussion.
Thank you, Virginia. Next, I have Libby. I'm sorry, I can't address you properly. Go ahead.
Oh, no worries. Libby is just fine. Thank you. I just wanted, to highlight, thinking back on the day again, I agree with everyone. Very excited to have a day to focus on communications. But also one concept that was brought up was this issue of guidelines. And I do want to be sure that we keep that at the forefront as we think about our response to this task letter, in that how we can be better at coming up with ways to develop the guidelines that will then in turn facilitate better communication, because there'll be more consistent guidance coming to the guidelines where all specialties can be represented on continuous guideline committees if there are standards around who should be at the table, which I think would be great, including, patients, all healthcare specialties. I've learned so much from being on the council about our partners in animal health as well as in agriculture. And I think having them have a voice on guidelines for various infectious syndromes would also be very helpful and informative. And so I just was really, that struck me today. And I just want to thank the council for the opportunity to give my comments. Thank you.
Thank you. Dr. Shefto.
Hi, I'd like to kind of layer on Dr. Fate's comments. One of the things that came through today really strongly was that we really need to focus on actual individual humans and what they are thinking, and to meet them where they are. And what's effective is to talk about individual empowerment, not societal ills or societal issues. But most of us on this council work at the population level, on societal level issues, not directly with individuals who are impacted. And so what also came through with Dr. Daly and others is that we need to work with the people who actually are trusted on the ground, the extension vets, the extension educators, the ag educators, if we're talking on my side of the line, the animal side, providers of all kinds, district epidemiologists. That's what we have at the health department, who actually talk to people. I do too, but not at the level they do. We need to they are our messengers, but their trust doesn't come automatically either. That's what Dr. Fate was saying, is that just because we say it doesn't mean that level of the people, is going to trust us or do what we say. So building the trust in that intermediate level is what we really need to focus on, I think, to get some of these bigger ideas across. Thank you.
Thank you, Dr. Sheftel. I don't see any other hands raised, so I'm going to take the opportunity to give my impressions of the day, which are very brief, and then turn it over to Dr. Blazer. Again, I'd like to thank the council and the panelists for their presentations and discussion. I think we've really highlighted the challenges of communication today, and there's one thing that really struck me, and that's the need to tailor the communication to the individual group that we are talking to and trying to communicate with. And one of the most powerful statements for me was that sometimes that just means being out in the community, that personal engagement and helping to put people out there for that personal engagement is very important, and that one of our biggest goals remains elevating the importance of AMR. So with that, I'm really looking forward to tomorrow, and I'm going to turn it over to Dr. Blazer for some closing remarks for today.
Great. Thank you very much, Dr. Apley. Thank you very much, everyone, for participating. We've had a very active discussion of the PACCARB panel, I would say, as per usual, but we've had really extremely interesting and provocative presentations by the panelists. It's a full day. We resume again tomorrow at 10 a.m. And I'm pleased to say I'm giving you guys 8 minutes back, 12 minutes back in your day. This meeting is adjourned.
Produced by the U.S. Department of Health and Human Services.